Good morning, bonjour tout le monde. Welcome to the fourth symposium on harm reduction. This is the second and hopefully last time that we will meet exclusively virtually. While streaming has certain advantages, it doesn't match the benefits of a face-to-face gathering. Nonetheless, the planning committee, the members are found in your agenda, have put together a strong program, and we hope you will enjoy the day. This year's symposium is called Time for a Safer Future. Over the years, the Planning Committee has sought to communicate a sense of urgency. The first symposium in 2018 was called Sounding the Alarm. The second was Keeping Watch. The 2020 event was COVID canceled. But last year, the third symposium was called Time's Up, and now Time for a Safer Future. And the time is long overdue. The mere passage of time has not and cannot lessen the incidence and impact of the overdose epidemic. 24,626 people have died from opioid overdose in Canada between January 2016 and June 2021. 372 deaths have been recorded in New Brunswick over the last 5 years. We hope that this symposium will add to your knowledge and critically examine the many factors that contribute to harms related with substance use. We'll talk about ways to prevent overdose deaths and other related harms, such as homelessness, mental health issues, and contaminated drug supply. This symposium is a unique opportunity to be open and talk with others about safe drug supply and safe housing. Thank you for joining us. There will be 2 short breaks between now and 4:30, the first at 1 o'clock and the second at 2:45. Feel free to use the chat room. Conversations will be monitored and relevant comments will be relayed to speakers and presenters. Let's get started. We'll begin with a land acknowledgement by Todd Ross. Todd is the Indigenous Advisor at UNB in St. John. You'll want to read his bio in the agenda to get a sense of the strengths and contribution he now brings to the region. Todd, over to you.
Thank you, Randy. Good morning. I introduce myself as Wabanakwa and I'm Eagle Clan. I acknowledge that the land on which we virtually gather is the traditional unceded and unsurrendered territory of the Mi'kmaq, the Wolastoqiyik, and the Passamaquoddy people. These territories are covered by the treaties of peace and friendship, which the Wabanaki people first signed with the British Crown in 1725. These treaties did not deal with the surrender of lands and resources, but in fact recognized Wolastoqiyik, Mi'kmaq, and Passamaquoddy title and established the rules for what was to be an ongoing relationship between nations. As we begin the symposium, this statement recognizing the territories and the treaties gives us time to reflect on what's happened in the past and what changes can be made going forward. The acknowledgement marks a small but important step in our journey towards reconciliation and is a way to recognize the enduring presence and resilience of the Mi'kmaq, Wolastoqiyik, and Passamaquoddy peoples, as well as the contemporary communities, which include many First Nation, Inuit, and Métis people from across Turtle Island who now call New Brunswick home. Thank you, Marcy.
Thank you, Todd. We'll next turn to Minister Dorothy Shepherd for some opening comments. Ms. Shepherd was elected first to the New Brunswick Legislature in 2010. She's held a number of portfolios and responsibilities with the government. She's currently the Minister of Health. Prior to politics, she was an active volunteer in our community, including an early supporter of the Women's Shelter and outreach services for women. Ms. Shepherd, it's up to you.
Thank you, Randy. I really appreciate being here this morning. Good morning, bonjour. I think that we can all agree that this pandemic has thrown a terrible wrench into the work being done to prevent overdoses and to protect vulnerable populations in our province. The momentum we were building was interrupted just when the people who needed us most either went into a lockdown or were put into an even more vulnerable situation as COVID spread through shelters and facilities and access to various services was impacted. L'automne 2019, juste avant la pandémie, j'étais encore ministre du Développement social. Notre gouvernement avait commencé à travailler sur le plan d'action sur la dépendance et la santé mentale. We held roundtables with stakeholders. We met with community leaders. We were formulating a 5-year addictions and mental health plan when COVID-19 threw our entire healthcare network into crisis. But despite all these challenges, we didn't let up, and neither did you. In September of 2020, I was appointed Minister of Health, but I continued to work with the team on the Interdepartmental Addiction and Mental Health Plan, which in turn has become one of the 5 pillars for our Better Together provincial health plan. Through the Interdepartmental Addictions and Mental Health Action Plan, we chose a globally recognized framework for approaching drug use, the 4-pillar approach. This approach, composed of the prevention, treatment, harm reduction, and community safety pillars, supports a comprehensive and multi-system approach to addressing this issue. It also recognizes the importance of compassion for those with substance use issues, with the use of supportive approaches, rather than simply tackling the problem by criminalizing those affected with the illness. 2 years later, we know the demand for mental health service has increased 16% in New Brunswick, with youth services needs up 33%. Wait times for high priority referrals are also up, and less than 50% of our citizens in crisis are receiving treatment within national benchmarks. We did have some success for individuals that were in isolation, and we have also made some progress. By embracing the step care model, we are recognizing the importance of compassion for those with substance use issues. By using supportive approaches, we are reaffirming the humanity and the dignity of people who seek treatment, and that we all share in the global objective of rebuilding wholeness, not only in these individuals, but in our communities. As part of the harm reduction pillar, we opened the very first overdose prevention site in Moncton. But there continues to be a need for similar sites and to expand harm reduction services. Overdose prevention sites are key to reducing negative health, social, and economic impacts of substance use on individuals, their families, and communities without requiring abstinence. Meeting individuals where they are at, that encourages connection to other service providers, and minimizing direct and indirect harm from substances. Creating safer environments for individuals that mitigate additional risk. Since November 1st, 2021, we have established 14 sites that offer one-at-a-time therapy, either by walk-in or by appointment. Horizon Health recently reported the wait lists for one-at-a-time therapy have been reduced by 54% over the last 4 months alone. This service not only provides enhanced access to mental health and addiction services, but can also support individuals to navigate to the right level of care and support that they need. As we move forward on this path, we recognize that the work isn't finished. We need to build on our most recent successes to continue to improve our response to those in need and to reduce the stigma. Key community organizations have received funding and supports in order to provide important service along the step care model within communities. We've also approved ongoing funding for the Parent-Child Assistance Program, PCAP, in St. John, a program to support families and women who experience addiction during pregnancy. I want to acknowledge and recognize the incredible harm reduction work being done by so many other frontline organizations, such as Ensemble in Greater Moncton, Avenue B, and AIDS NB, working together as the New Brunswick STBBI Community Alliance. I couldn't begin to thank you all for taking part in this symposium. I've looked at your agenda. It's going to be very, very interesting, and I hope to stay on and hear some of it with you. But please know that I'm so appreciative of the commitment that you have vitally to this important work. And I look forward to our going forward together to help bring these resources to community. Thank you so much.
Thank you, Madam Minister. Let the learning begin. The next session will deal briefly with the Alliance in discussing the power of partnerships. The Alliance is a wonderful example of the evolution and strengthening of the community sector in our province, and how with strong leadership, capacity, and collaboration has blossomed. We're joined this morning by two outstanding advocates whose names are known well by those of us from New Brunswick. Julie Dingwell is the Executive Director of Avenue B, located in St. John, and Debbie Warren is Executive Director of Ensemble, located in Moncton. Over to you, folks.
Good morning. So I get to start this off and thank the Minister Shepherd for doing such a brilliant opening and really laying the ground for what we want to talk about. Because really this is all about how do we keep people alive? How do we stop putting names on our memory wall? So I'm going to tell you a little bit about Avenue B. We began in 1988 as AIDS St. John. We've been evolving ever since. I began with the organization in we started in 1988. I began in 1999, but I want to tell you that we were one of the early organizations to provide needle distribution, and we began actually in 1992. But, you know, when I started in 1999, we exchanged 799 needles that year. And I remember thinking, that is so many needles. But you know what? This year, we're going to exchange over 460,000 needles. And that's not even taking into consideration that thousands of safer smoking kits that we provide. So we have meth pipes, we have crack pipes. So you know, we've been trying to expand and make it so that people can just access us. However, so, you know, when we talk about the power of partnerships, we have about 7 other agencies that distribute supplies in the city on our behalf. So that's what partnerships can do. We have the Sex Trade Action Committee, with about 20 partners that come together monthly to sit around the table. And you know, that was a committee that started with our St. John Police Force, because police officers kept saying, look, this is a health problem. This is not a policing issue. So now we have this great committee. We come together monthly, we share information, and that way we can help make things safer for people who work in the street sex trade, and we can make residents happier about what's happening. So, you know, I just wanted to take a minute. I was going to go to Paris in July and present at a conference called Justice in Mental Health. And I'm not going to go because of COVID. I'm a bit of a chicken. I've decided, no, I'm not going to go there right now. But you know, the premise of my talk was going to be about what if we did everything different? What if we turned things upside down and started looking at how we might do things differently? And I'm going to give you a quick example because I think that it just sets the stage. So where I work, downstairs, there's a methadone clinic. So one day, as I'm looking out the window, this young man comes up on a bike, parks the bike, goes to go in and get his methadone, but no, he's tackled by 2 policemen, brought right down to the ground. He's handcuffed, put in the car, and he's taken away. So my whole thought around that was, one, because then we found out, of course, he's got later charges because he's been all upset. But you know what? Why wouldn't we let him go in and get his methadone first, then come out? And so then he's not jonesing all day. He's not arguing, pushing back police and getting further charges. So these are little things, you know, little things that we can do to show a little bit of kindness to enable people to move forward, because it just takes that little bit to switch things around, you know, and that one little act would just do so much. So, in talking to you, I don't want to take time away from my colleague in Moncton who has some pretty exciting stuff to share too. But we're busy here in St. John. We've got a new build that's going to happen. Hopefully shovels are in the ground any day now. We're going to have a safer consumption site in that building and provide housing for chronically homeless women. So I think that, we all know what we need to do. We all know that we need safe supply, that we need to make just treatment far more accessible and meeting people where they're at. So if we already know how to do those things, you know what I say? Let's get on with doing them. And let's start today. We know what needs to be done. Let's start right now. And let's do it all with a little bit extra bit of kindness. And I'll turn that over now to my friend Debbie Warren in Moncton.
Hi, Jules, and thanks for that. Yeah, Julie and I could probably take your whole conference time, but we're going to be respectful of all the others who have so much to contribute. And I just want to thank the organizers for having the Alliance to talk about the work we do provincially, to share the work, and hopefully we all learn together. I'm just going to give you, I'm trying to do a 5-minute overview of what we do and just give an idea of what it looks like in an organization such as ours. I mean, we were formerly AIDS Moncton and have worked for years with Julie at Avenue B, formerly AIDS St. John, and also AIDS New Brunswick. And so we've got a great partnership, and we know there's strength in partnership, and we share our expertise and resources. So at Ensemble, I guess informally, because we didn't have any formal program nor supports or funding for it, I started dealing needles out of the corner of my desk, one needle at a time, while we were waiting to get resources in place. And so we've evolved, over time from a whole gamut of services and support for folks who use substances. And, I always just say, I wish you could get to know them like we know them. It's pretty emotional for me because they're everyday New Brunswickers and they don't always get the best of consideration and respect. And so the services we've created have been for them, informed by them. And so we have our harm reduction education, where we have created resources for healthcare and service providers so they understand and know best practices relating to substance use, like what's a cooker, what's a rig. And so we have information for them. We also do training around stigma and discrimination, around use of language, recognizing that addictions disorder is a complex health issue. I'm going to share, like Julie did, a real life situation. Our folks often won't go to the hospital for their serious infections because of how they're mistreated at the hospital. So this one young man, he was tossing up, we have two major hospitals, which one should I go to? So he decided on, and I'm going to name it, let's throw the bouquet where it belongs, at the Dumont. And when he went in, you can imagine it takes some courage to, admit he's a user, admit that he injects. And when he got beyond that with the nurse sat him down and she says, hey, let's look at those veins. And what we're going to do, first of all, is we're going to find one good vein and you're going to keep it for me. So if I ever have to give you treatment or save your life, we have a vein. You have no idea the impact on that young man's life. He came back to us literally over the moon to think that she did not judge him, she did not shame him, she cared about him, and she demonstrated the care. I wish all of the folks we serve got that kind of treatment. So that's my message to all of you in healthcare and service providers, is look beyond the shabby clothes, the teeth missing, the sores. There's a human being, and let's do that. And that's what we try to do in our stigma and discrimination education. We also teach about overdose prevention, naloxone administration, and we also share that with people who use substances so they know about bevel up and not to share. And our needle distribution service, like Julie mentioned, the numbers they had, it used to be a big thing for us to pass out 50,000 needles in a year. This past year, 733,000 needles. The issue has exploded in Greater Moncton. We have over 1,300 unique individuals, mostly in the age range of 30 to 49 years of age, 60% male, 40% female. The staff do training with community service providers around needle safety. We've partnered with the city of Moncton and downtown Moncton, and they've purchased and installed drop boxes around the downtown area so that people can dispose of needles safely. They've helped us create and provide for the general public a needle safety brochure. And we also have partnered with rural pharmacies and outreach services and shelters to give them resources to pass out. And we have the distribution of naloxone kits for folks to take home, whether they use substance or they have a family member. Minister Shepherd mentioned the overdose prevention site, and I just want to thank her for her efforts to make sure that happens. This service has saved lives in the short time that it opened since November 25th. We have over 100 unique individuals, and upon intake, they all have indicated, all 100 plus people, that they are either precariously housed or in fact homeless. So they have no other place to use safely than at our location. The frontline staff don't have any degrees behind their names. They're just frontline folks in the trenches, have experience with homeless or people who use substances, and they've been trained in CPR and first aid just so that they are able to respond to an overdose. We have a spectrometer so we can test the substances, and we're working to create a peer-led program. And I can tell you, just in the past month, in a very short time, within less than 2 weeks, we had 5 overdoses. And there was also one in the community that one of our peers was able to administer naloxone. Those 6 lives were saved because we had the service for them. Unfortunately, there were a couple of other incidents in our community where they weren't so fortunate, and the outcome was not at all what we wanted to have happen. Some of you may have heard about our interactive dispensing service, known AKA as a vending machine, but this is not like any vending machine you've seen. Think of a vending machine with an iPad on the front. People are able to access whatever we dispense inside, outside. And that evolved because of COVID funding. We had to shut down for a period, then we had to limit our services, but substance use is 24/7. So this afforded us the opportunity to set the machine up, and people are able to access it when we close our office, so between 4 p.m. and 9 a.m. And we have one in Moncton. We have one that's hosted for us at Sackville United Church. And we soon are going to have one installed in the Rishabakdo Guardian Pharmacy. Again, partners, we could not do this without partners. The city of Moncton has been so supportive in trying to address this issue with us. They funded a full-time position for a wellness navigator. So, and Horizon Health gave us some startup funding as well for this position, but it's really to provide that one-on-one support. So it's not us telling people what they need, it's people coming to us and saying, I could use help with this. So whether it's to access social development, apply for housing, reconnect with family, whatever, we're able to provide them with a cell phone and airtime. Thanks to UNB nursing students and Horizon, we have transportation to get them to appointments, remind them of appointments. So really that wraparound support for them. And those are folks who access any of our services. We also are fortunate, another great partner, Vitalite Health Network. They provide us with a nurse practitioner. Right now, it's 2 afternoons a week, and I'm really working to make that much more than that. But she's able to provide primary health care. Often they don't have access to family physicians, and to address some of those infections so they don't avoid going for health care and that they don't develop into soft tissue infections or endocarditis. And those are by drop-in or appointment, because their life is pretty challenging. They survived yesterday and they have to survive today. They have to find shelter to sleep out of the cold. They have to find food to eat. So that's a lot of work on their part. So they aren't good at keeping appointments, and we need to recognize that and not penalize them. We also, as a result of the funding for the overdose prevention site, again, drop in or by appointment, we have a social worker to provide counseling to them. And I'm mindful of my time, but I really exciting news. We've been working with Dr. Sarah Davidson and her team at Riverstone Recovery Center, and we're very hopeful that by early summer, we will be able to provide the injectable opioid and stimulant agonist therapy to the folks that come to our service. So you can see that we've really tried to develop a center, could always use more floor space, I'll tell you, but a place for people that they can come, that they're treated respectfully. And that's always the resounding, I get so many hugs from people and thank yous from people, just that they have a place to come and that our team is so respectful and treat them like the humans that they are. It's heartwarming. Again, I wish you could get to know them like we know them. They're all super unique individuals. But, you know, we do the day-to-day stuff. We really need to look at systemic changes, as Julie referenced, you know, and we need to work in research that informs some of that. And so along with, you know, Avenue B comes right along with us, and some local committees like them, we have the Greater Moncton Homelessness Steering Committee. We've worked with the Community Task Force, which was led by the Greater Moncton Chamber of Commerce. And we had a local overdose prevention site steering committee of local stakeholders, including people with lived experience, that really helped us to set the foundation for our overdose prevention site. And that will carry on. Along with Avenue B, we also serve on the Atlantic Interdisciplinary, it's a hard word for me, it's like saying spaghetti when you're two, research network. And the current project involves people who use substances, families, and healthcare providers. And it's about identifying what treatments and supports are available, but also what are the challenges and barriers to accessing those supports. And so we've heard some great things around distance and cutting people off from family. And so that will help us to inform and advocate down the road for services. We're also part of the REACH research project, I'm Ready, which is the HIV self-testing kits. And so Avenue B, A's New Brunswick, and Ensemble are the three distributors in the province. But I'm also on a national committee under REACH, and Dr. Sean Rook from St. Michael's Hospital leads this. It's a national committee, and it's about the Health Box project, and you haven't heard about it. And I hope I'm not letting too many cats out of the bag, but it's about establishing interactive dispensing machines, like our nice vending machines, across the country to dispense the testing kits, the harm reductions, and guess what? We're #1 in New Brunswick. Ensemble was like the model unit, and we're building on trying to get up to at least 10 of them around the province, including our First Nations reservations also. So we're really excited about that as it's just starting to roll out. We're also connected to the Dr. Peters Center, which is in Vancouver, and it's a national network of supervised consumption sites and overdose sites, where we get learnings and support each other in the work that we do. That's an invaluable resource for us. And we're also involved in the Canadian Drug Policy Coalition, where we're advocating to decriminalize drugs for personal use, and also to advocate for a safe supply. So that's a really quick rendition of some of the things that we do. But at the end of the day, it really needs to be trauma-informed, focused, and to understand that addictions is very complicated. And it's not just, like I mentioned, the 1,300 people we serve, plus that's not just 1,300 individuals, that's 1,300 families in our community. And, you know, I'll just share one little more real life incident. So in the media, they were talking about these overdoses that we were having from a bad drug supply. And I got a message from someone who was inquiring about a particular individual who I couldn't say yes or no had access to service, but the 13-year-old daughter of that individual was worried about her dad. So without giving any confidentiality away, I was just able to say that all of the incidents that we dealt with at our facility were successful, and the persons were doing well. So it's not just the individual, it's that 13-year-old child. And I want you to always remember that every day you serve someone who's struggling with their issues. Thank you for having us.
Thank you very much, Debbie and Julia. Or Julie, rather. Sorry, I'm not the only one to have made that mistake. Julia was on the CBC this morning and interrupted, and I think she's going to be joining us tomorrow morning on CBC again to talk more about the work that's happening in St. John. We had a last-minute regrets from Amanda Diggins, who was going to join the other two speakers and talk about the work that's being done in AIDS New Brunswick. New Brunswick has a lot of geography, and with apologies to Stephen Leacock, not a lot of people. But I think it's important for us to acknowledge that AIDS New Brunswick has offices in Fredericton, Miramichi, and Bathurst, as well as operating a mobile outreach programs throughout rural New Brunswick. I'm not aware of any questions that may be in the chat for any of the panelists to date. So maybe we could turn then a little early to Dr. Tommy Brothers, who's going to be speaking about, can we make hospitals safe for people who use drugs? Dr. Brothers helped organize Halifax's first safe injection site. His clinical and research work focuses on improving healthcare for people who use drugs. Good morning, welcome, and thank you for being here, Dr. Brothers.
Thanks very much, Randy, and all the organizers for having me. It's wonderful to see such a turnout. Can everyone hear me okay and see the slides? Great. So as Randy mentioned, I'm a medical doctor. Most of my clinical work is based in the hospital. And my focus in education and research initiatives has been trying to figure out how to improve hospital care for people who use drugs. Debbie shared a really powerful story earlier about the potential for improvement. And my title about can we make hospitals safe for people who use drugs is meant to be a bit of a provocative challenge, implying that right now most hospitals are not safe. But of course, we want to aspire to something greater and make hospitals a place of healing and caring for people who use drugs. Just to start with some acknowledgements, I live and work in Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. I don't identify as a person who uses drugs and won't claim to speak from that perspective today, but the information I share is made possible by the generosity of people with lived and living experience of criminalized drug use who have shared their knowledge and experience with me. And that includes colleagues and friends, as well as my patients. And I have no relationships with the pharmaceutical industry. There are 4 key messages that I'm hoping you'll take away from this session today. The first is that people do not give up their right to healthcare just because they use drugs, even though some of the policies and practices in hospitals might imply that they do. Second is that patients come to the hospital for necessary and needed medical care, often as a last resort because they've had such negative experiences there, and not necessarily because they want to stop using drugs. So it's not fair for us as hospital-based health professionals to assume that people are able or interested in stopping right now just because they need antibiotics or surgery. Number 3 is that hospital policies that require abstinence, and these can be written or unwritten, but that require abstinence in order to receive medical care create harms for people who use drugs. They're not neutral, they're actively creating harms. And I'll walk you through some examples for those that may not be as familiar with the hospital setting. And finally, the hospital should strive to at least offer the standard of care provided by community-based harm reduction programs, including the ones that we've heard from so far. But of course, recognizing the amount of resources that hospitals have that community-based organizations don't, of course, we should aspire to offer even more. So we've already heard today about a lot of the threats and risks facing people who use drugs, the toxic and poisonous criminalized drug supply, discrimination and stigma, pushing people away from healthcare, lack of housing, of affordable housing, creating the harms associated with homelessness. And in order to navigate these social harms and get through the day, people who use drugs rely on a wonderful network of harm reduction programs and organizations that we have in the Maritimes with a rich history, as we already heard about this morning, for things from social connection and support and navigation, practical supports with sterile injecting equipment and naloxone, opiate agonist treatment, methadone, Suboxone when they need it, if people need a break, support with housing, all these kinds of things. But when it comes to hospital settings, places that are supposed to be healing and caring, not only have we traditionally not offered those services, we haven't taken that philosophy of care, and we've often barred these kinds of supports at the door. They're not invited into the hospital. People are not on the care team. There's no communication and coordination. And as I mentioned at the beginning, often abstinence is enforced or expected in order to follow the hospital rules. So hospitals have been conceptualized as high-risk environments for people who use drugs. The abstinence-only policies, the lack of harm reduction support, and stigma keep people away from hospitals because of these negative experiences until, for example, a skin infection might worsen and become more severe and enter the bloodstream and spread to the heart. They lead to inadequate pain and withdrawal management, people having terrible experiences in hospital, and they lead to people leaving hospital before their needed medication and other treatments are done because of the hostile environment that we've created. So the end result is increased morbidity and mortality, increased suffering and death, horrifically and terribly for people who use drugs when hospitals are supposed to be places of caring. I'm going to just show you briefly some of the research evidence around this. This is a bit of an older paper now, based in Vancouver, but it shares the stories of people who use drugs who have been in hospital. And this is based at St. Paul's Hospital in Vancouver, which is really a leader in terms of integrating harm reduction into hospitals. So some of the policies they have now weren't in place at the time, but at that time they were still thought to be a leader back in 2014. So I have 4 quotations that I'm going to share with you. And I apologize for those with lived experience in the crowd that these may provoke some strong feelings, because the stories of how people are treated are quite awful. I had to get out of there while I could move because I was losing so much weight. I begged and begged to get some help, i.e. prescription opioids for treatment and relief of withdrawal. They weren't going to do anything. So I just said, fine, I'm leaving. I was concerned about the health consequences of leaving hospital, but I've got this other thing, opiate dependency. And it's like you're stuck between a rock and a hard spot. I mean, how can I fight off infection if I can't stop puking and shitting? Second, the security guards yell and scream at you. When there's nobody around, they say, "You effing junkie." A few times I've been shaken down or searched by security guards, even though I had nothing to get high, no drugs in their possession. They search you, destroy your property, cause a scene, and make sure everybody in there knows you're a drug addict. They use their authority to pull power trips, more or less. It's not right. So, here we have people seeking medical care, trying to engage in the treatment that they need, and being forced into withdrawal, being judged, being discriminated, and getting pushed out of hospital. And as we know, that loss of opioid tolerance that comes with forced withdrawal can be deadly as soon as people leave hospital after a period of enforced abstinence in the hospital, with higher risk of overdose. 2 more to share with you. The nurses don't give you rigs or syringes. I think they should. If not, we're reusing our rigs. We're having a risk getting kicked out for stealing them, or people will be sharing them. I know one girl was using her same rig for days to the point it was tearing. She was suffering every time she'd do her fix. She just didn't have it in her to go and try and steal clean rigs. Whereas for me, my friend I was with had no problem. She would sneak in and grab some for the both of us. And the final one here, if you're sharing a room with somebody, there's always that threat that someone's going to come in and not realize you're in there in the bathroom and open the door. I think they pretty much have a zero tolerance in the hospital, a zero tolerance policy for substance use. I was worried about getting kicked out and not getting the proper healthcare I needed to get better. I'd turn on the tap. So if they came into my room to check to see if I was okay, they'd hear the water running. So they'd figure, oh, she's just in the bathroom. So here we have examples of the hospital policies and practices creating risks that wouldn't necessarily be there otherwise. So someone who relies on a needle exchange, a harm reduction program for their own safety to use clean and sterile equipment is denied access to it, even though they're stuck in the hospital because they're a patient. So they're having to reuse blunted, contaminated equipment, increasing the risks of infections. And somebody who uses substances, presumably every day, doesn't have a safe space to do so, doesn't have people to use with. And so they have to lock themselves into a bathroom because they fear getting kicked out of the hospital, even though they need treatment, so that nobody could respond with naloxone if they overdose. So this is kind of some examples of what I'm talking about with the policies and practices creating harm, creating a hostile environment. This is an example of the qualitative research. I just want to show you an example of the quantitative research of the consequences of some of this harm. So this is a study published this year I was involved in. We looked at all of the opioid overdose deaths in England in the past 10 years and looked at when they happened in relation to when people were in hospital. We found that the couple of days after hospital discharge, people are at a 4 times elevated risk of a fatal opioid overdose. And if they're discharged prematurely against medical advice for those reasons that we talked about, the risk is increased 8 times. So the harms conferred by hospitals are quantifiable. I would argue that they're preventable and reversible, and we'll get into some examples of how that might happen. But I think all of us who work in a hospital setting there's many reasons, obviously, why we have a mandate to do better. So how are we doing locally? I want to show you some local data next. This is a project, the paper was published this year. The data, we looked back a bit older for the time when I started residency from 2015 to 2017. And that's because this was the practice environment, these kinds of issues of how things were in Halifax when I started my training in medical school and residency. And so we wanted to try to identify what happens to people when they come into hospital in Halifax. I had learned about some of the great work going on in St. John, some of the initiatives led by the Division of Infectious Diseases and Duncan Webster. And so those hadn't been evaluated. So we wanted to compare the experiences of people in hospital in St. John and in Halifax. And we wanted to identify the people who would be, we would argue, at highest need of all of these supports. So we found the hospital admissions and records of patients who are admitted with endocarditis from injection drug use. And for those who maybe aren't medical, endocarditis is a bacterial infection of the inside lining of the heart and the heart valves associated with injection drug use. And it can be very dangerous. It can be deadly. People need to stay in hospital a long time. And so these are the folks we argue would be at most need for all of these supports that we're talking about. So the hospitals in Halifax and St. John are a bit different. The situation that existed in 2017 is still largely the same today. So as I mentioned before, both hospitals have harm reduction programs and organizations in the community that offer all of these sorts of things we've been talking about. Both hospitals are also highly specialized. With lots of resources. They're the main teaching hospitals for the Dalhousie Medical School. They have cardiac surgery programs if patients need operations on their heart valves. They have infectious diseases specialists, cardiologists. At the time, St. John had some institutional policies that acknowledged substance use and incorporated harm reduction, including an inpatient needle exchange and needle and syringe distribution program, which I believe was the first in Canada. At the QE2 in Halifax, we don't have that. We still have no policies, and we've had to really do things on a case-by-case individual basis while we're going through that slow process. And as I mentioned, St. John has the inpatient needle exchange. In St. John, the infectious diseases physicians and some of the other hospital-based physicians got extra training in prescribing methadone and buprenorphine or Suboxone so they can offer it to people who are in withdrawal or interested in starting treatment. In Halifax, back in 2017 and still today, there's nobody on staff that has this training or is able to start people on medications, which is kind of amazing if you think about it. So again, we've had to go outside the normal rules of the institution, and I'll show you that after this. Neither hospital, as far as I know, folks in St. John, please correct me if I'm wrong, have a role for someone with lived or living experience of substance use on the hospital care team. So that's also something we can aspire to. This is just some brief examples of the policies in St. John. The original needle exchange policy. There's process maps for identifying and urgently treating opioid withdrawal with methadone doses, and protocols, checklists to facilitate that care with as few barriers as possible, which we also haven't had in Halifax. So the first thing that we looked at was access to opioid agonist treatment. So as I mentioned, patients who use opioids who are in withdrawal, and these were folks who were not already on methadone or Suboxone or KDM when they came into the hospital. So these vertical bars here, the black is Halifax, the white is St. John. 100% includes all of those patients with endocarditis from injecting drugs who used opioids. The next pair here is who was offered opioid agonist treatment in hospital. So because the infectious diseases specialists in St. John prescribe these medications and can initiate them in hospital, 100% of these patients were offered it, whereas less than half in Halifax were. Obviously a huge gap of unmet need and a huge difference between the two hospitals. But if you look at these next two pairs of columns, the third one is how many patients actually started it when it was offered. And the final one is how many continued on with a prescription after hospital discharge. So most patients, once it was offered in hospital, were interested in trying treatment or starting it with OAT, and were interested in continuing on after hospital. So lots of unmet need, but lots of opportunity for people who are, unfortunately very sick from serious bacterial infections related to injection drug use and homelessness and all of the criminalization and all the harms we've been talking about, but are interested and open to starting on opioid agonist treatment. In terms of who was provided sterile injecting equipment in the hospital, as I mentioned, St. John, I think was the first program in Canada. That policy was developed on their internal medicine unit where some of these patients, many of them were admitted. If you look at the left column here, this was 21 hospitalizations to people in hospital with injection drug use associated endocarditis in Halifax. None of them were offered sterile injecting equipment in hospital, perhaps not surprising because there was no policy in place. There still is no policy in place. And unfortunately, 5 patients or almost a quarter had their own equipment identified by hospital staff and confiscated. So these are people who are trying to be safe, who are trying to use sterile equipment, and the hospital is actively making it worse and actively creating harm, as we talked about before. Compare that to St. John. On the right, 4 patients, or just under a quarter, were offered sterile injecting equipment in hospital. That's wonderful. It's obviously not everyone, but it's great that some people have access to this and did at the time. And yet 2 patients also had their own equipment confiscated. These were different patients at different hospital times, but one of the same units actually was offering patients equipment at one point and confiscating it at another. So, policy can be more consistent. Obviously, it takes a lot more to implement a policy in terms of education and practice norms than just having it on paper. So perhaps a lot more room there in terms of the inconsistency, but better than nothing, we would argue. And then the final thing we looked at was patients' experiences in the hospital and indicators of unmet care needs related to substance use. The information source where we got this was the medical records. So this relied on charting from nurses and physicians and pharmacists and social workers. So I'm imagining that this is an undercount in terms of what happened to people. But remember that these are folks with life-threatening bacterial infections. And so my argument is that we should be doing everything we can to support people to stay in hospital, to be free from pain, to get their antibiotics, to get their surgery if they need it. In this first row here, you can see most people at both hospital sites, there was documentation in their medical record about providers' concerns that the patient was experiencing uncontrolled pain or undertreated opioid withdrawal. Around a third in both hospitals, there was documented concerns about ongoing substance use in hospital. Of course it happens, right? Patients were injecting drugs yesterday, injecting drugs this morning, got a fever and a bad infection, came into hospital. Of course, they're still going to need to inject, or many of them will. And so hospital policies need to acknowledge that this happens and need to support people to do it safely. And finally, around 10% or 1 in 10 of patients at both hospitals left their hospitalization prematurely before their treatment was completed. So what more can we do? How can we make things better? I'm going to show you one version of my menu of things that I think are easy for hospitals to achieve, things we've been working on in Halifax, and I know folks have been working on, including some who are here today, have been working on in St. John. I'm going to read you my menu and then give you some examples of each. So in hospitals, we need to provide compassionate care, culturally safe care for people who use drugs. I think Debbie gave a great, powerful example of what that might look like this morning. I'll give you a couple more. We need better staff education, training, and culture change around substance use in hospital. We need people who use drugs involved in leading service planning and delivery. We need opiate agonist treatment on demand. You saw there that most folks who are quite sick would like a break, would like to try opiate agonist treatment, and we need to be able to offer it to them. And continue it if they're already on it. Of course, people can't go without and be experiencing withdrawal unnecessarily in hospital when they're trying to be well. We need to offer short-acting opioids like hydromorphone, morphine, Dilaudid for pain and withdrawal, whether or not people are starting on opiate agonist treatment. We need to distribute safe injecting equipment in the hospital, including needle disposal kits, but people should have unlimited access so that they can stay safe. We need to incorporate safe consumption sites and overdose prevention sites into hospital. As I mentioned, of course, people are going to be using in hospital. We want them to stay. We want them to access their treatment, their medical treatment, antibiotics, surgery, that kind of thing. So we can't be creating environments where people need to lock themselves in the bathroom or leaving the hospital grounds. And I argue we need specialized addiction consult services or perhaps just medical substance use services to be able to take on these higher prescribing doses, to be champions of culture change. That could be addiction trained physicians and nurse practitioners and nurses. Or it could be the infectious diseases specialists taking this on for these patients with endocarditis, like the folks in St. John have done and been leaders in. So I'll show you some examples of each. So what would culturally safe care look like for people who use drugs? This was a research project done in Victoria, BC, a collaboration between the drug user group there, Solid, and researchers at UVic. And they got together and asked their membership, how would you like to be treated in hospital? How should care providers treat you, and what would help you feel safe? So there's a few recommendations they came up with. The first was to foster engagement and participation of people who have experience with substance use and marginalization and shaping the care they and their peers receive. Number 2, recognize people's healthcare and priorities and experiences are influenced by history and policies that criminalize drug use. Number 3, consider how past histories of trauma and violence, layers of disadvantage and stigma may affect patients' ability to engage with providers and care plans. Number 4, emphasize relationships and trust as priority outcomes. I do really appreciate this one. Sometimes as medical people and clinicians, there's a lot going on in people's lives that's outside our control. And for example, people will need to leave hospital kind of no matter what we do because they have other priorities. But I appreciate that people who use drugs are asking us to treat those relationships and trust as an ends in their own right, as an outcome in their own right. And finally, promote a culture of respect and safety within the unit or workplace where all patients are valued and seen as deserving of care. So these are teachings and lessons that we're incorporating into our educational sessions with physicians and nurses and pharmacists and social workers, and medical students, I should say, and trying to change some of those attitudes. I don't think that this would necessarily be a controversial way to treat any patient. You know, as health professionals, we talk about patient-centered care. I think these are great examples of that. It just sometimes takes a special invitation when we're having to unlearn a lot of things about how drug use has been criminalized and how people who use drugs are. And one story I appreciate about this project, Bernie Polly shared, who's one of the lead researchers, was the drug user group developed it in order to, post these handouts on the wall and share them with providers and say, you should think about providing care this way. And then the drug user group Solid started printing it out and handing it out to their members. And so when they went to access care or they went to the emergency department or hospital, they bring a handout with them and say, this is how I want to be treated. And this can be incorporated in a hospital policy. So this is an example from Alberta Health Services. It's an overarching province-wide health policy guidance document for all of Alberta Health Services. Some of the language has been changed since the new Conservative government came into power, interestingly, but it's a model for us that we've been borrowing from in Halifax as we're developing some draft policy changes. So this is in the written province government policy. Patients who use psychoactive substances have the right to receive equitable, non-judgmental, and evidence-based healthcare services, regardless of whether the substances they use are legal or illegal. Individuals with lived experience have expertise to contribute as partners in the creation of programs, policies, and harm reduction strategies designed to serve them, and their input is valued and respected. Obviously, that has to be met with funding and logistical and institutional support for that expertise to be incorporated on the leadership team. And finally, program services and healthcare providers across the care continuum shall provide low threshold access to harm reduction services, treatment, and or referral for patients. So every setting on demand, all of these services should be available. In Halifax, as I mentioned, we haven't had anyone on hospital staff, physicians, or nurse practitioners that has the skills or takes it within their scope to offer opioid agonist treatment initiation in hospital. So we organized a team of residents that are working at the hospital, supervised by and led by addiction physicians in the community. Some of you may recognize these names. John Fraser, who's been in practicing and leading this work in Halifax a long time, has been our primary supervisor and mentor. We would be able to do that with this without him. So this team operates outside of working hours, evenings and weekends, and gets referrals by word of mouth, text message from our peers in the hospital. We offer all patients who use opioids, short-acting opioids for pain and withdrawal to help them stay in hospital. And we offer everyone opioid agonist treatment. And in our evaluation here, we found almost all patients with untreated opioid use disorder who were in hospital with serious complications from injection drug use started treatment in hospital, and almost all of those who started continued it at discharge. So we argue this is a huge unmet need, a huge gap in care. If there's anyone here from Nova Scotia Health, please connect with me afterwards. We've been trying to get funding to make this service real and resourced and available during business hours since 2018, but we still haven't gotten anywhere. An example of how a needle exchange can be incorporated into hospital. I showed you briefly the original one from St. John. This is from Providence Healthcare in Vancouver. They call it, this is a nursing care guideline. They call it the Unsafe Sharps Risk Support Plan. The argument is that if we do not offer patients sterile injecting equipment in hospital, that leads them to have to hold on to their used equipment and hide it under their mattress or hide it in the peanut butter drawer and reuse it. And not only does that create harms for the patient in terms of risks of infection, as I mentioned before, but that's where the risk of needle stick injuries from hidden needles might come to hospital staff, including nurses and housekeeping and that kind of thing. So by offering patients an unlimited supply of sterile injecting equipment and a disposal kit, we're not only helping people stay in hospital and stay safer, but we are helping reduce the risks to staff as well. So like lots of harm reduction. This is win-win for everyone. But of course, people use drugs in hospital. This is the reason that we have to give them sterile injecting equipment and disposal kits. So we need safe consumption sites and overdose prevention sites in hospital as well. This is one where we're a bit further away from achieving in Halifax. So this is an example of the supervised consumption site at the Royal Alex in Edmonton. It's a a room inside the hospital. They have 2 different injection rooms and a chill out room. It's available to hospital inpatients or patients registered in the emergency department. It's staffed by nurses, and they've used this infrastructure to build in an injectable OAT program, so liquid high dose hydromorphone, in the same infrastructure. So patients who are admitted in the hospital can come here and use and not miss antibiotic doses and not have to leave the hospital grounds and be able to stay safe and stay inside. A different model of an overdose prevention site at St. Paul's Hospital in Vancouver. It's been in their courtyard behind the hospital. It's been in a trailer in that courtyard. It's been in the ground floor basement of the hospital. But it's staffed by peer workers with lived experience of substance use from a community organization. It's accessible by patients who are in the hospital, but also just by community members in the surrounding area. And it's really minimal. Like I mentioned, it was a tent, it was a trailer. You don't necessarily need, as we know from overdose prevention sites, you don't necessarily need all of the expensive infrastructure, the medical professionals or healthcare professionals. These services can be much more effective if they're staffed by people with lived and living experience of substance use. So these are just a couple of examples of what it could look like in the Maritimes. We can incorporate the supervised consumption site model, the medical model, or simply put an overdose prevention site on the hospital grounds for anyone to access. I want to share, to wrap up, a couple of key resources here. If you hold your cell phone camera up to the QR code there, it should take you to a Google Drive folder that has the paper that I shared with the data from Halifax and St. John, and also these resources. So one is an overview that Duncan and John and I wrote in CMAJ on some key principles in caring for people who inject drugs in hospital. And the second one there is from a group at McMaster in Hamilton about many different aspects of how hospital policy can be transformed, or as Julie challenged us to think of things upside down, to support people to stay in hospital and make hospitals a caring and safe space for people who use drugs. And I've learned a lot from that group and incorporated some of those ideas into this talk today. And I'm happy to share these slides as well, of course. So to wrap up, I just want to repeat the key messages that I was trying to communicate with this session. The first is people do not give up their right to healthcare just because they use drugs. Second, patients come to hospital for necessary medical care, not necessarily because they want to stop using drugs. And so we need to help people stay alive, as Julie mentioned, and treat the needed medical problems while supporting them to stay safe. Number 3, hospital policies requiring abstinence create harms for people who use drugs. They're not neutral and they need to be changed. They're causing people to die, as I shared with that quantitative study. And number 4, hospitals should strive to at least offer the standard of care provided by community-based harm reduction programs. But of course, I argue with all of the resources and specialized everybody available at the hospital, we should aspire to have even more. And finally, this is my contact info if people want to reach out, but I hope we have time for questions and discussion now as well. And thanks again for inviting me to speak on this topic. It's something I care deeply about, but it's obviously a work in progress for us in Halifax.
Hey, Tommy, it's Sarah Gander. I'm your chat question person. So I've just been watching a really dynamic conversation in the chat throughout your presentation. And thanks as always for being awesome. So lots of support and lots of kudos to you for all of your hard work. One question that came out in the chat was just sort of what your wish list would be in the Atlantic provinces for what research and scholarship we could be doing that in particular might meet our specific needs. So whether that be our specific needs like related to the drugs that we do see in the Atlantic provinces, or if there's a specific issue with our law enforcement in this region or what have you. Do you have any thoughts on what research could kind of be the next thing that might, keep the momentum going?
Yeah, do you mean specifically related to hospital care or kind of more broadly, more generally related to?
The question was asked overall, but I think because they spoke about sort of police and things like that, but I just think like what would be next in sort of better understanding the path that we should take moving forward?
Yeah, I have a couple thoughts of that. It's a really important question. I think the fundamental way to get at what's most important would be if people who use drugs and the drug user groups we have in Atlantic Canada can be supported to participate in setting that agenda and asking those questions. And I know SUNAR has been doing really great work doing that. I know PWUD, which is now based in Dartmouth, Nova Scotia, has been doing that at a national level. Debbie mentioned the national networks, the ongoing study in the Atlantic looking at access to treatment. Most of the answers I could give you are really ideas that have been shared with me from people who use drugs, about our changing and unstable drug supply in the Maritimes, where previously pills have been widely available, and now there's more and more pressed pills that are actually fentanyl and all the different contaminants and are no longer safe for people. So there's more and more of a role of safe supply. The way that medications like safe supply can try to counteract some of the social harms like homelessness and poverty and violence that are facing people's lives. But my real answer to your question would be, I'm probably not the best person to answer that. But our emerging and established drug user groups in the Atlantic should be at those tables, supported to be at those tables, paid for their expertise, and invited to set that agenda for us to follow.
Yeah, for sure. And I wanted to, there's a couple of questions. Well, one is that if you mind sharing your slides, which knowing you, oh, there you go. Maybe you're already sharing them. Is that what that Google Drive link is?
That's the link to the Google Drive with the papers in it. Oh, and I also
okay.
I didn't mention there is one best practice guidance document on caring for people who use drugs in hospital that's published out of that group in Alberta. And there's a PDF of that in that folder as well. And that's what we've been bringing to hospital leadership and saying, this is what's established as best practice, and this is what we have to aspire to meet. We're not kind of making this up as we go. And I'd be happy to, I'll pop my slides into that folder so that everybody can access them as well.
Awesome. So one of the questions was, where do you think from a hospital standpoint, some of these facilities or infrastructure opportunities for folks is best located, which is actually kind of what my question is too, but maybe I'll let you answer that and I'll dovetail onto that.
Like physically located, or
yeah, I think so.
Yeah.
So the question reads, I realize this program crosses over in all departments in the hospital at like QE2, but where in your opinion do you think it is best located? Oh, look it. And the person said yes, that I must have got it okay. So like physically located.
Yeah, I think that different components of it can be located in different areas. I think there's obviously some aspects of changing care and changing culture and changing practices that really do need to be distributed across the whole hospital. So for example, our team that's trying to take this on is comfortable prescribing higher doses of opioids than many other physicians would be. And so if they can reach out to us and we can go and participate in caring for that patient and guide medication dosing or take over medication dosing, whether that patient is admitted to a surgical floor or a medical floor or anything like that, like that's incredibly important. Can we distribute sterile injecting equipment throughout the hospital in many places so that people can access it? Maybe a vending machine would be really helpful so that people don't have to disclose and can get it anywhere. One of the restrictions on safe consumption sites and overdose prevention sites is that they're kind of geographically fixed. So having it in a location that may be a bit more private to access, but is still open to the community could be a win-win. There's a treatment unit at St. Paul's in Vancouver that was previously their inpatient AIDS unit that's been redesigned and reorganized to support people who use drugs who are admitted to hospital with complications of injection drug use. And by keeping all those folks in their hospital beds in the same area, they're able to offer a multidisciplinary team that involves people from the community that they know and representatives of all of the housing and harm reduction programs that can come and be part of the care team. So that kind of having a specialized area in the hospital that we could offer to people would be wonderful. So it's not really to answer your question, but I think some things need to be hospital-wide, some things can be concentrated, and then perhaps they should coordinate themselves together.
Yeah, well, I think some of the chat was, it's fine. It's all well and fine to have some of like the great initiatives that we have here in St. John, say on like one nursing unit, but then if you can't extend that to other nursing units, like you kind of never know when somebody might be somebody who would benefit from those services. And so how does it kind of cross the hall to the other nursing unit. And I think someone mentioned that then even if the nurse or one of the healthcare providers has that experience, you know, it's almost not an accepted practice in a different place. So how can we kind of make it more ubiquitous and available out in the community and in the different hospital areas? So
Yeah,
that's
I
more
think
just
that's
a comment
where
than a question.
No, yeah, and that's great, and something I've been thinking about a lot as we've been trying to kind of change culture and attitudes. And I think it's a good example of where education and stigma reduction are necessary but not sufficient. Like they can do so much, but if you don't have policies in place or college regulations in place or things written down on paper that say, this is how we should be thinking about these issues, this is the type of care we want to offer, this is how we want to embrace people and keep them safe. You know, attitudes can be positive, but people's practices are quite limited. So I've learned a lot from nursing colleagues about what they feel they can or can't do because of real or unclear restrictions on their practice from the nursing college. And we've seen similar things happening with the medical community and safe supply prescribing, where people feel like they can't embrace a harm reduction practice because they would fear their license from their regulator. So, you know, education and stigma reduction is important. Explicit hospital policies are necessary. College standards are necessary. And so there's a lot that has to happen at lots of different levels for this to be successful. But I have some really funny conversations with people when I talk about this stuff, and they say, hey, why haven't we been doing this the whole time? Like, why are hospitals so hostile, and why haven't we been doing? I'm like, I don't know, you know, like I'm sure there's
well, except for we kind of do know.
Yeah. all the discrimination and the stigma and the criminalization and things we've been talking about, for sure.
But they're very difficult.
There's really no reasons we can't, basically.
Yeah. There's so many questions, Tommy. So I hope just settle in. So, because we've got lots of time. And to continue on to that vein of thinking, we have a anonymous attendee who sort of said, from an educational side, how are we working then to integrate this mindset and approach in educational institutions in making changes before folks enter the healthcare working environment? So do we have an opportunity to work with educators too?
Yeah. We've had a really positive response from nursing educators at the QE2. We've had a really positive response from the medical school and the people that make the curriculum. But honestly, the most encouraging response has been from the new generation of students, of nursing students and medical students and pharmacy students. Like, I think in so many ways, the young folks, the Generation Z, are going to save us. It's people are looking for educational opportunities when they're entering the health professions. People want to learn how to do this. It felt horrible being a medical student and participating in care that was creating harm for people who use drugs. Like, I could tell what we were doing was wrong, but I just didn't know what we could do differently. And it was clear on our team, you know, we operate in big teams in the hospital, being supervised, different levels of seniority. Nobody felt good about it. There was a lot of moral distress. There was a lot of people asking questions, but really not connecting the dots. And so where I've learned so much has been from the community harm reduction organizations, from people who use drugs, and just trying to bring these established ideas, these evidence-based ideas and practices into the hospital and say, hey, you know, there's people outside these walls that have been doing this for decades. We should think about doing it here. So there are lots of opportunities, I think, to improve medical school curricula, nursing school curricula, educational in-services. We've had a bit of a struggle connecting with bedside nurses because of the way that their shifts work and people not being able to all take breaks at the same time. But that's one thing where these specialized consult services can make a huge impact, because every patient that we care for together with a nurse at the bedside can be opportunity for dialogue and two-way education and learning about best practices and evidence and learning about the realities of providing care in the hospital and all those kinds of things. So I think there's lots of opportunities. I don't have a single best answer, but you know, leveraging the expertise of community-based organizations and inviting them into the schools and the hospitals, I think is key.
Mm. You know, I wonder too about my own personal experience working in the hospital, and particularly with COVID and the pandemic. And so this has sort of triggered me to ask this, you know, when we were working with COVID and some of the regulations, albeit early, you know, particularly during the early days when there was really little to no flexibility with how we let people move around in the hospital, or, you know, and it wasn't just in injection drug use. It was going out for a smoke. It was going out to grab, Wendy's so you didn't have to eat the hospital food, sort of thing. How can we learn from the pandemic in terms of meeting people where they are, where sometimes you do have to come and go and have some privacy and move amongst places to meet people's needs? Because I think we are still seeing in the hospital that you're kind of, when you come in, you're like, especially if you have COVID, you're in your room, you're not going anywhere, you're staying in that room, nobody can come see you, you can't leave. And there's some good reasons for those decisions, but then, and really no flexibility about how to meet people's needs. And then what would happen? People would get upset, there'd be a code white, they'd get, the police would come and then here we are in the same re-traumatizing situation we're trying to avoid.
Yeah, COVID and the visiting restrictions and the mobility restrictions in the hospital have been really horrible. And, even more so, like most things, people who use drugs have taken the brunt of those harms. I think it's a good example of there's some things that are bigger picture, like infrastructure changes are needed, private rooms are needed, better ventilation and infection control. These are more expensive, longer term projects. I think later this afternoon, one of the discussion topics is on COVID and harm reduction, but with every crisis comes opportunity. So as people have had to isolate, it started in Halifax with the hotel shelters. I was on a team with MOSH, able to provide people emergency managed alcohol and safe supply medication, so they had to isolate. And we have taken that approach to some folks in the hospital on the COVID units, who we're basically asking them to do the impossible and stay in hospital when they're sick. And be able to provide safe supply in the hospital on a individualized case-by-case way. So some of the problems are massive and are going to require big, expensive structural solutions. Some of them, I think, require looking for those opportunities to continue to try to stay dynamic and creative, and provide the best care we can to help people do things that we're asking them to do that are impossible, to help people stay safe. So always that mindset about, what more can we offer when we really do have the infrastructure and the resources, and it's just a culture change, a practice change, or a logistical change.
Mm-hmm. Yeah, just an anecdote on my end is just when parents come in with their child, and because I'm involved in the population, sometimes I know that the parents might be on methadone or Suboxone. And if everybody has COVID, nobody can bring them their medications, and the parent isn't actually the patient. So it's just then you have to find all these workarounds to get them their medication, or else they leave and they take their kid with them. So it's a problem. Tommy, I just want to get to some of the other questions and not take up all the airspace here. So today in the news, there was an article that a school in Moncton was unable to take the kids out to do a cleanup for Earth Day due to the number of dirty needles on the property. Should engaging teaching of harm reduction be an avenue in the schools? We see this around our clinic. Me and my kids, we found a whole mason jar full of needles, just 5 blocks in each direction. So it's a big problem. So I'm not sure what the question is, other than maybe education is beyond just healthcare providers, but rather into schools and with our educators as well.
Yeah. I think education is crucial. As I mentioned before, the limitations on education, I think, are just that policy needs to match it in terms of supporting people to change their behaviors and change their attitudes from a caring perspective. I'm not familiar with that news article in Moncton, and obviously it's unfortunate when kids can't, do their whatever they were going to do outside and feel safe. But I think, as Debbie mentioned, the local organizations are picking up and cleaning needles as much as they're distributing them. And I'm aware of the peer programs in Atlantic Canada where people who are still using or using drugs are being paid to go out in the community and connect with people and pick up those needles. And so I think there can be wonderful opportunities in that as well to help empowering people while keeping everybody in our community safe.
Mm-hmm. Mm-hmm. Some presenters talked about those vending machines. So the question is, did they have to pay for that product? Who's buying these lovely vending machines that are out there?
Yeah, I imagine it depends on the program, and we don't have anything like that in the hospital in Halifax. So I'm aware some of them are more expensive, kind of higher technology with like palm print scanners and stuff. Those are some of the ones that are doing for Safe Supply. But some of the other folks here, Debbie, might be able to speak more about funding sources. But like all public health interventions, it takes some investment to see the benefits to keep everyone safe. So I think it's great if it can help people access harm reduction with fewer barriers.
Yeah, and there was a comment sort of about what about engaging local businesses, sort of local community members that would have an invested interest in keeping their areas safe, and could they, be part of that solution? And then one of the audience members talking about models in Ottawa where, and we have this in St. John too, sort of a powerful local advocate looking into like smoking cessation programs that are like, just, very operationalized. And so, is there something to learn there that we could use and kind of piggyback from in terms of drug use? So yeah, and lots of people who just want to connect with you. So I suspect you'll get some emails.
Oh, great. Yeah, happy to chat. And like I said, we're working on all this stuff in Halifax. So folks who are already doing a lot of these things in hospital, I'd love to learn from you as well.
Awesome. I've been looking at the Q&A. So, can Tommy speak more to the safe consumption site in the Royal Alex in Edmonton?
Yeah. I don't work there. I got to visit a couple of years ago during the stimulus conference. So I know things are changing all the time. But it is a dedicated set of rooms in the hospital, accessible from outside for emergency department patients, but accessible for inpatients. In a part of the hospital that's a bit separate from the rest of the clinical inpatient unit. So people can just head to the elevator, head down a hallway, and not necessarily have to be visible that they're accessing the site. And it is run kind of under the auspices of their specialized addiction consult team, which they call ARCH, which stands for Addiction Recovery and Community Health. And it's a multidisciplinary team with medical nurse practitioner, prescribers, social workers, people with lived experience as peer support workers. So because it's kind of in this medical model, they do keep track of who's accessing it, whether that person has been referred to their specialized team or not. And then they're able to check in with people if they're needing to go to the site. Do they need more substances to kind of take with them? Are there unmet withdrawal and pain needs that they're having to go and use and inject, and that kind of thing? So they, like I mentioned, don't have to leave the hospital grounds, don't have to lock themselves in a bathroom, but can just go and use and inject indoors. There's no smoking component to it because it's inside, as far as I know. So that's another potential gap that could be met with a more creative model to support people who are smoking, but like smoking, crack or fentanyl or whatever. Yeah, I don't know if people have more specific questions about it, but that's kind of how the model works.
Yeah, it was coming from Duncan Webster. So I'm going to call you out, Duncan. But and then I think you mentioned that they are collecting data and sort of watching what happens as they initiate these things. So that was one question. But can they use their own drugs, or is it only hospital prescribed drugs? And then are there any other sites beside the Royal Alex in Canada?
Yeah, as far as I know, the rooms are kind of split now into a safe consumption site that people can use their own drugs, and which they would have had to get somewhere, and their injectable hydromorphone opiate agonist treatment where people can come and get liquid hydromorphone to use there to inject themselves rather than have a nurse administer it. The full description of the program was published open access in CMAJ a couple of years ago. I'll put the link there, and I'll also throw that into that folder. And I can share a link to the folder again. And then in terms of elsewhere, as far as I know, at Royal Alex in Edmonton, St. Paul's in Vancouver, and Casey House, which is an HIV specialized hospital in Toronto, are the ones that have integrated safe consumption sites or overdose prevention sites into hospital care. But if we can locate these sites in a place in a city that's next to the hospital grounds or on the hospital grounds, and maybe more accessible for people who are still sick.
Awesome. Thank you. Hopefully that answers some of Duncan's questions, and I'm sure he'll find you if he has more. And Linda, I think I messed up your question. It wasn't who's paying for the vending machines. Do people have to pay to use the vending machines to get stuff and things that are available through the vending machine, or is it just for free? Is that
I see there Debbie's written all items are free, which I think might be in response to that
perfect.
question.
Sorry.
But yeah, that's depending on the vending machine and depending on the program, that's my understanding, because it's all about engagement and access, right? Like getting people the things they need to stay safe. So provided for free generally, if we're talking about sterile injecting equipment, or provided through programs and provincial insurance if we're talking about medications for safe supply.
Beautiful. Okay, Tommy, do you want me to let you off the hot seat because you've answered most of our questions? And always wonderful to have you, and thank you so much. And Randy, I will pass it over to you.
Okay, thanks everyone. Bye-bye.
Thank you, Sarah.
Tommy.
Thank you, Tommy. That was wonderful. We're off to a great start, and we've got a few extra minutes here that I think people might be able to enjoy before we convene back again here at 1:15. If that works for everybody, well, then why don't we sort of take a 25-minute break and come back at 1:15. Thank you all. See you soon. Welcome back, everyone. Thank you for joining us again. The morning sure set the bar pretty high. So good afternoon and good morning to our Western friends that are joining us. A couple of short notes before we start again. First, to our sponsors. Both Gilead and AbbVie have been consistent sponsors for us from the very beginning, and we couldn't be doing this without them. So a shout out to those two corporate sponsors for us. Secondly, of course, to Dr. Sarah Gander, who can add monitoring chat rooms to her long list of abilities and skills. Stand by, Sarah, and we look forward to hearing more from you this afternoon. And finally, to the planning partners who participated year after year after year in putting together this symposium, and their logos and their identities are found in the materials that you have, and I commend them to you. This afternoon, we'll start with Nancy Henderson, who'll be speaking on the need for safer supply and decriminalization, evidence from current research and practice. Nancy's joining us from Toronto. They are the Safer Supply Program Manager at the 360-degree nurse practitioner-led clinic in Peterborough. Lots of other interests and responsibilities of Nancy are found in your materials, so I welcome you to check those out as well. And now I'm happy to turn the floor over to Nancy.
Thank you, Randy. Yeah, I'm just going to get started here. I first need to set a little disclaimer that the views expressed here do not necessarily represent the views of Health Canada. A few objectives today. We're going to look at the drug poisoning crisis and why we need to address the stigma and criminalization of people who use drugs, explore barriers and enablers to opioid agonist therapy and safer supply, and understand the need for the scale up of safer supply programs and advocating for decriminalization, legalization, and regulation of all drugs. Because I work in a sector that is trying to address social injustices and harms, and before I can talk about harm reduction programs that are meant to counter the war on people who use drugs and the violence of its criminalization, I must first acknowledge that these harms originate from a history of colonialism and through the genocide and exploitation of Indigenous and Black people. From this, the values, institutions, and systems that were formed and continue today, including everything from policing to prisons, education, housing, and healthcare, were all founded on white supremacy, anti-Black racism, and ideologies of superiority. These systems are not flawed, but rather the deaths we see of Indigenous and Black people are inherent to it and will continue if left unchecked and unchanged. All of these systems need to be dismantled and rebuilt by the community, not in consultation with the community. So with this land acknowledgement, I just want to recognize the colonial violence that continues to this day. And I acknowledge the territories I'm speaking to you from and on which I work, live, and play belong to and should remain under the full jurisdiction of the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. From January 2016 to September 2021, 26,690 people died from opioid toxicity poisonings in Canada. And it is believed that by March 2022, we surpassed 30,000. 20 people died every single day from January to September 2021. And for a comparison, there were 7 deaths per day in 2016, the year that the drug poisoning crisis was first declared in British Columbia. This is no longer a situation where people are overdosing. This is a crisis where people who use drugs are being poisoned by a toxic street supply of unknown quality. The street supply is no longer contains fentanyl. The street supply is fentanyl and its analogs, which now also contains benzodiazepines and other adulterants. Drug prohibition, which has deep roots in colonization and racism, has led to today's war on drugs. But this war on drugs is actually a war on people who use drugs, and it is based on what we now know are decades of failed drug policies and systemic racism. The drug poisoning crisis that is now in its 7th year is not a criminal justice crisis. It is a public health and policy crisis. The war on people who use drugs exists because substance use has been seen as a problem with the individual rather than a broader systemic issue. In the early 20th century, drug use disorder was considered to be a defect in character since this person chose to use drugs despite prohibition and social disapproval. People who use drugs were seen to be weak, immoral, and foolish. And that meant that there was no need to look at the problems of inequality, poverty, or familial breakdown that could be coexisting with the person's substance use. The Global Commission on Drug Policy wrote in 2017 that this partially explains the paradox where most citizens believe in the failure of the war on drugs, but they continue to support policies that call for more resources being put into this so-called war. They want to continue to see that this is a problem with the individual that can be dealt with by enacting strict policies and harsh sentences. So why is it that the number of deaths due to drug poisoning continue to increase? Why is this 6-year state of emergency still a crisis, and a crisis that is not abating? We have seen through COVID-19 pandemic that when governments work together, there can be a robust and often effective response to a public health crisis. So why are we not seeing it here with the drug poisoning crisis? It comes down to stigma. And in order to combat the stigma and harm directed at people who use drugs, we need a public health approach that is grounded in human rights and health and social equity. How do we get there? We need to start with the policy changes that take us from the criminalization of certain drugs to the decriminalization of all drugs. And we need it to be a policy change that it goes into effect across the entire land that we call Canada. Under the current state of criminalization, we have been told that abstinence must be our goal. Because of this belief, the gold standard treatment for opioid use disorder is opioid agonist therapy, or OAT, which consists of Suboxone, methadone, and sometimes Cadian. These are long-acting medications that are part of an abstinence-based model. So why not invest more money and time into OAT to curb the rate of deaths? When these medications work, they work really well, but retention rates are low, client perception of treatment is waning, and many people have been failed by the abstinence-based punitive model. People who use drugs need another option, and this is where harm reduction and safer supply comes in. What sets safer supply apart from OAT is that the participant's goal does not have to be abstinence. It can be whatever they choose it to be. We need a variety of services, but with criminalization, some people who use drugs avoid services that are there to help them, such as consumption and treatment services, OAT treatment services, and even gear distribution. Because of the stigma and criminalization that exists, people who use drugs who do access service do so at the risk of experiencing discrimination, dehumanization, and stigmatization. Before talking more about safer supply and decriminalization, I'm going to provide a few examples from how this has played out in my own experiences. So during my early years, I experienced some trauma that negatively impacted the rest of my life. I was what you would consider a good kid that got good grades, but as a youth, I struggled with an eating disorder and depression. I was in and out of hospital, so I missed a lot of school and then therefore like typical teenage socializing. Then there was an incident that changed things. What followed was a series of events that led from me being removed from my home and placed into a women's shelter in a neighboring community. and then being removed from the shelter and taken to a hospital in a city about an hour away. Once placed in the city, I didn't return home. I was alone, without supports, without family, without friends, without my dog, without anything familiar. I was a country kid who had been displaced into a big city without having the resources to be able to figure things out. I've often wondered who exactly thought that this was a great idea. And I wasn't in any position to be able to be making these kind of choices. When I left the hospital, I was placed in a group home for young female identifying people who were all in somewhat of a similar situation. It was at this group home that I found exactly what I was looking for. It was here that I found the escape from the realities of my life that I really was seeking. It was here that I found drugs, and I got fairly good fairly fast. I stayed in this group home for a little while, but I was eventually asked to leave because of this newfound choice in drugs. With no money, no job, and no high school diploma, I quickly realized that I would need to fend for myself on the streets or within a very broken shelter system. This would be my reality for the next few years. My drug use escalated and I used whatever I could get my hands on, but I definitely gravitated towards using stimulants because it was a way to keep myself alert and I felt it kept me safer. I wasn't doing that great with the youth shelter system, so I migrated into the adult shelter system, where unfortunately resources were more sparse for a person my age, but I found some people who started to look out for me. This entire experience of being on the streets, in and out of shelters, living in extreme poverty, all while dealing with substance use and mental health issues, was trickled with criminalization and stigmatization. I was criminalized for sex work and fraud, both of which were means for me to get the drugs I needed to survive my life. Drugs weren't this thing for pleasure. They were a way of coping, and they were survival. The main harm reduction service I used at that time was the Site Ban, a needle exchange program that existed in the 90s in response to the AIDS epidemic, and was actually first initiated by people who used drugs in the 80s. It was 1-for-1, unlike today. So if you brought in 10 or 100 rigs, you got the same number in return, which meant that there was often not enough to keep up with my habit. The van would park at specific places throughout the city, and the police were told to leave us alone, but they were never that far away. It was scary to go sometimes, and the whole process of having to count out what you were bringing in felt very stigmatizing. And there was always that fear that you could be criminalized for carrying what you needed to be safe. So I got off the streets in the late 90s, and I spent the next decade or so immersed in housing instability, food insecurity, mental health challenges, and trying to practice harm reduction for my substance use. How I managed to get off the streets is a bit of a mixed bag of connections I made with staff in the shelter system who went out of their way to help me at times, and connections with random people who crossed my path and would offer me a place to stay. Ultimately, I was one of the lucky people who staff broke rules for, and unfortunately, rules being broken is sometimes the way that you have to do things in order to really help somebody. I tried to get into some day programs, but addiction services wouldn't take me because I had eating disorder, and eating disorder places wouldn't take me because I had addictions. Dual diagnosis just wasn't a thing. So I made a decision to create my own day program. It was January. I lived about 6 blocks or so away from the adult high school. So my new plan was to go back to school. With the help of the staff at the shelter I was staying at, I got enrolled, and it was to begin in a few weeks. I didn't have a lot of time to reconsider, and I was petrified. So I spent the next few weeks immersed in drug use, and with the plan that I would quit on my first day of school. I definitely showed up on that first day. My plan didn't go exactly as I had hoped. But I just put figurative blinders on, and I, like a racehorse, and put my head down and just focused on school. I sat through classes, and I remember one person in particular every morning in biology class would say, "Hi, Nancy, how are you?" To which I'd respond, "Good, you?" And I'd keep on walking, not waiting for the answer. I eventually, I didn't have a long-term plan with this, but I was meeting my short-term goals, and I eventually graduated high school. I want to skip ahead and talk about a period in my story where I fell and hurt my back. I had been working at the time, I went, because of this back injury, I was involved in physical therapy and I was receiving opioids, trying to control the pain and trying to get myself back to being able to work. My life was already a mess at the time, but this definitely made it worse. And I found myself once again caught up in addictions. But because of the interaction between my meds and that I was taking and the opioids I was getting, everything abruptly stopped because of a serious health concern. In response, I was taken off some meds and went into withdrawal and had a mental health crisis. Everything's a bit of a blur, but I was sick. I was anxious. I thought I was losing my mind. And although most, as we heard with the last speaker, that most experiences for people with substance use and mental health issues is not pleasant at an emergency room, at this one day, I pleaded for help and they actually listened. I am beyond grateful because I know that the ending of this story would likely be very different if it weren't for this day. I have thankfully not had to rely on the toxic street supply of fentanyl at any point in my life or any point in my story. So the rest of this is very privileged because of that fact. On this day, they gave me just enough to keep me well. And I was in a space where I was completely okay with this because I was done. I wanted to stop. But eventually they sent me to an addictions medicine doctor at a clinic because the prescriptions weren't going to go on forever. And this is where my experience with OAT comes in. Regardless of the medication I was on, a process of getting there, or how things turned out, I consider myself one of the lucky ones who came through this experience being deemed as successful on traditional OAT. However, even with this apparent success, I was not spared the humiliating, dehumanizing, and stigmatizing experience of being part of this punitive program. From the moment I walked through the door of the OAT clinic to the moment I walked out of the pharmacy with my prescription, I was labeled and treated like a drug addict who could not be believed nor trusted. The most humiliating part was providing urine samples while being watched on a live video camera that was in the wall next to the toilet. It was a childhood fear of someone peeking in on you when you're in the washroom come true every single visit. And I intended to be truthful about my drug use, so it didn't make sense to me, but the trust just wasn't there. I didn't like the experience, yet I feel grateful and lucky to be deemed a success. In what other situation does success feel like this? And don't get me wrong, my doctor, all of the staff, everyone was very kind and supportive and tried to make the experience as good as possible. But ultimately the experience was not great because the very design leads to the stigmatization of people who will be caught and penalized for whatever is deemed to be wrong. Even if the doctor doesn't want to do it, they sort of have to. We need OAT treatment. We desperately do, but we need change within it. And we need something different for those who have been failed by or who do not want to be part of this traditional system. So life threw me a bunch of curveballs after walking away from substance use. But when I would get to these places, I look back at what worked in the past and I would decide to put my focus into school again. It worked once, so I decided to just keep trying it. The next time this happened, the only program starting at the community college that was close to me was a personal support worker program. So I went for it. I never wanted to be a PSW, but I needed a goal. I was doing well, so the nurses who taught the classes encouraged me to enroll in the Bachelor of Science in Nursing program to become a registered nurse. Again, I didn't have a great desire to be a nurse, but I needed a goal. And although I was filled with a tremendous amount of doubt, I just decided to go for it. 4 years later, I graduated. Through nursing, I found my way to give back to the community that I left behind. I have been working with people who use drugs and people who are unhoused since before I graduated, and I am so grateful that they let me into their lives. I realize every day that I lucked out. I didn't ever have to be entrenched in a crisis that is killing my family and my friends. I didn't ever have to experience the immense grief and loss that is now embedded in the lives of people who use drugs and their families. I didn't ever carry the same type of fear in knowing that this hit could be the last. This is all of this is not okay. And it is up to all of us to listen to what people who use drugs are saying and to fight for and create change in our communities. All of these experiences and reflections have opened my mind to new opportunities that offer an alternative option to people who use drugs, and options that weren't available 10, 20 years ago. And these are things like safer supply and the idea of really getting decriminalization to be a policy change. With decriminalization, all of the experience that I just explained could have been different, because as it stands today, drug use is a criminal activity. So anything related to that drug use could potentially be criminalized. With decriminalization, we can break down barriers to people accessing harm reduction, safe supply, and treatment services without people fearing criminal charges, stigma, discrimination, and dehumanization. Once we take away the stigma and the criminalization, we can see it as a health concern with the root causes based in things like trauma, housing insecurity, and poverty. When we take the shame away, we can actually talk about it openly. Drug policy is a public health issue and needs to be removed from the criminal justice system. What needs to be done is basic and core to health practice. The solution is pragmatic. We need to look at what is causing the harm and then look at how do we address that root cause. We need to ensure that people who use drugs feel safe to access the services that are there for them and for them to be able to reach their own individual goals, whatever those goals may be. It's important to remember a few things about decriminalization. First, people who use drugs need to not only be heard, but they need to be central to this process every step of the way, because they are the ones subject to the harms associated with criminalization. Second, we need to center the voices of Black and Indigenous people because they are being disproportionately affected by the criminalization of drugs and drug policy. In Toronto, Black people make up 9% of the population, but between 2015 and 2021, they were subject to 30% of the simple possession charges, and this excludes cannabis. Third, we need to listen to the often silenced voices of female identifying and gender non-conforming people. In BC, 80% of the women who are incarcerated are there because of drug use, and over 50% of those women are Indigenous. Putting the people in jail for drug use disrupts families and divides communities. This is a systemic racism issue. This is a reconciliation issue. We need to address these harms. And decriminalization is just one part of the equation. It's just the first step. We also need low barrier and high quality harm reduction, safer supply, and treatment programs, because people who use drugs need options to meet their own personal goals. We need a community-driven model that offers voluntary supports for people who use drugs. This model needs to be separate from the police and instead be centered around community organizations that are already doing this work. We need to meet people who use drugs where they're at and when they need it. In order to offer high quality programming, the government needs to expand access to medications like injectable hydromorphone, diacetylmorphine, powdered fentanyl in appropriate formulations through the provincial drug benefit formulary. And we can't forget that we desperately need affordable housing, basic income, social services, grief and trauma counseling, recreational therapy, access to nutritious food, and the list goes on. These lead to a reduction in harm as well as improvement of dignity, autonomy, health, and well-being of the individual and the community. In light of the escalation of opioid-related poisoning deaths across the country, there is a great need for rapid expansion of safer supply programs. Similar to the guidelines from BC, our work in Ontario has been informed by the existing evidence base and the living expertise of people who use drugs. Our work in program development has been done in response to community level advocacy, which made it clear that community-based solutions are needed urgently, that we can't wait for government-led scale up, and we need to act swiftly. The first guiding principles of safer supply is to ensure the program is non-punitive and based in harm reduction. We can't allow them to become completely medicalized or people won't use them. The second is that people who use drugs are experts and central to planning, implementation, and evaluation. The remaining guiding principles are all focused on keeping the participants central to their care, that access is easy, and that we are engaging in a consistent and appropriate manner. I started working in Peterborough, Ontario in April 2021 on a Health Canada SUAP funded research project, and it had a pretty small budget. The goal was to explore barriers and enablers to safer supply programs with the option to potentially create a 10-person pilot program in June 2022, if there were people willing to prescribe. There was an advisory committee of 6 clinicians when I started, but because this is harm reduction focused and a program where people who use drugs need to have a voice, we added 6 additional people to the committee. And they were people who work in harm reduction. I also created a lived and living experience advisory committee of 7 people to further inform this research. And I hired a person with lived experience of opioid use, someone from this area who had a more relevant experience than I had. And this person worked with me on data collection and analysis for the section on people who use drugs. Unfortunately, I wasn't able to have them in the entire project. First, I'm going to talk about the focus groups with people who use drugs. 21 of 23 participants said they are currently using street-acquired fentanyl. When looking at how people consume their fentanyl, 7 said they inject and 14 said they're smoking. This points to the need for inhalation boosts at consumption and treatment sites because more and more people are smoking their fentanyl for a variety of reasons. And they are at great risk of drug poisonings all the same, especially when they have nowhere to go to use their dope safely. 23 of 24 participants said they're currently using street-acquired stimulants. This supports the reports of increased polysubstance use and the need to be looking at safer supply for stimulants as well as for opioids. Drug poisonings are also more complex to treat when multiple substances are being used, so we need to be aware of this. 20 of 24 participants said they had drug poisonings in the past 6 months. Of those, 5 had 1, 7 had 2, 5 had 3, and 3 people had 5 or more drug poisoning experiences. Half of the participants said they had done some sort of treatment for their substance use. Of those, 9 had tried opioid agonist therapy, with 2 currently still on the program. 6 people said they had tried OAT 5 or more times. 2 had tried twice and 1 had tried once. This points to the need for more options so people aren't having to continuously go back to the same thing that wasn't working. Some barriers to opioid agonist therapy, they called methadone liquid handcuffs because of how stringent and punitive the program is. They feel judged, stigmatized, and not heard by the OAT teams, and access such as transportation and clinic hours were a barrier. Although they said when it works well, and that it's easy to get on, they would prefer to go to their own doctor or nurse practitioner than go to a methadone clinic. They also report that they want people with lived experience providing services for them, and they want access to counseling and support. When looking at safer supply barriers and enablers, there isn't a safer supply program in Peterborough at the time of this, so this was potential barriers and enablers that they were thinking could be an issue. Again, they spoke about judgment, stigmatization, criminalization, the lack of choice in medications and doses, not having access to basic needs, especially affordable housing, and a lack of support at the shelter because at this time, the shelter in the community is not providing harm reduction. Some enablers to safer supply, they see this as another option for them and they want to be treated with respect and trust. Again, they want people with lived experience to be in these locations. They want options for appointments and medication delivery to be in a clinic or on outreach. They want options in counseling, and they want culturally specific resources. Again, basic needs, especially housing, came up. And interestingly, from a report that I was reading, there has been a doubling of opioid-related deaths among people who are unhoused in Ontario since the beginning of the pandemic. Now, 1 in 6 deaths are among those who are unhoused, which reinforces the need for safe and affordable housing as a social determinant of health. I then did interviews with ordering and service providers. I spoke to 17 people, with the majority being from Peterborough City or County, and 5 were selected from existing safer supply programs in other communities. The majority have been working in their role for 1 to 5 years. Percentage of clients with substance use disorder in their practice was 5 to 100%, with 7 stating that they work exclusively with people who use drugs. 5 people said prescribing or dispensing safer supply, and this was predicted based on targeted recruitment. And 2 people stated that they prescribe or dispense opioids to clients with opioid use disorder, but they're not calling it safer supply. Of those 7 people prescribing, 1 feels fully supported, whereas the other 6 feel either not supported or only somewhat supported. Of them, 1 person feels supported, and the 1 person who feels supported is the 1 person who has cross coverage. So they have support from other prescribers to cover their caseload when they're off or for after hours calls. This really urgently points to the fact that we need more prescribers willing to prescribe and to cover each other. Some barriers to opioid agonist therapy from this group were program model too regimented and not accessible, lack of individualized care, poor retention rates, client experience includes stigmatizing and judgmental care, lack of communication between the prescriber and the methadone clinic, and not addressing basic needs or needs with regards to pain. Enablers to OAT, they wanted to have a flexible and accessible program model, a holistic care approach to care. The clients need choice in medications and access to health and basic needs. And clients should be able to set their own goals and strive to reach those. Barriers to safer supply, sustainability. These programs are not sustainable. They are all limited funding through the SUAP program. People want more evidence. Evidence is coming, and there is evidence that exists, but people, before they get involved, want to see more. Accessibility is a barrier. The community judgment, stigmatization, criminalization was again brought up. Lack of choice in medications and lack of access to basic needs. Enablers to safer supply, a need for flexible and accessible model, more education and buy-in from the community, holistic supportive care, and stable funding. Client experience includes more choices in medication, increased communication, and access to basic needs. In every single group that I spoke to for each of the enablers and barriers, that need for basic needs being met, especially housing, was consistent. As I mentioned, I started with a small budget and a plan to maybe do a 10-person pilot program, but I was the only staff hired other than my research assistant with very minimal hours. And we were uncertain as to how we could truly help the individuals that started on with a safer supply prescription. In June 2021, additional money was made available for existing SUAP programs to apply for an amendment. We were told that we would need to operationalize the proposal quickly because funding was going to end March 31st, 2023. On December 22nd of last year, an announcement was made and our amendment was approved. So we now have $1 million budget from Health Canada's SUAP program. It's going to be based out of a nurse practitioner-led clinic with plans to include an outreach component as per the research. The Safer Supply team consists of health, social, and harm reduction services. And really importantly, 7 of the 10 people who are on this team have lived or living experience. So this means that we have not only an advisory committee, but we also have an abundance of experience within the team from frontline to management positions. It will be a 50-person pilot program with gradual enrollment beginning in May. Program planning, implementation, and evaluation will be guided by the research project and the advisory committees. We're going to rely on our community partners, especially harm reduction partners. We're going to do public education and awareness presentations and create a local community of practice with the hopes of getting more people involved. And we'll continue robust research and evaluation with participants, staff, and the community. Just a really quick glance at the results that came out of London, Ontario earlier this year. First, clients started in London in their Safer Supply program in January 2016. By April 2020, they were up to 112 clients. They received SUAP funding at that time. And since then, up until September 30th, 2021, they enrolled another 152 clients and lost 16. This is a 94% overall retention rate. This is unheard of in treatment services. And currently they have approximately 250 clients in their program. And of those there, they are also receiving not only a prescription, but they are also accessing health and social care. Some of the benefits people experience include reduced drug poisonings, increased health and social service access, reduced emergency room visits and hospitalizations, and reduced contact with the police. Even if unsure about the practice of safer supply, it's hard to argue with the amount of money a program like this can save in things like policing and healthcare and judicial costs. And the reasons people want on the program are similar to why people want OAT or IOT programs. Ultimately, they want to change lifestyle and stay alive. There will always be challenges to a medicalized model of safer supply, especially because of the strict criteria to get on and the highly demanding model that these pilot programs have. People who use drugs have been telling us since it started. And there simply isn't enough funding being offered to be able to fully provide what people need, including that lack of affordable housing in communities. Looking at some of the recommendations that came out of the London program report, the need for more prescribers, provide clear information, so transparency on what is happening. They suggest that you should have a consumption and treatment site close by, which luckily Peterborough was just announced that Peterborough is getting a consumption and treatment site very soon. Education, pharmacy support, and expansion of program and medications. On a system level, the Ontario formulary needs to include high dose injectable options, diacetylmorphine. We need to address stigma and discrimination within healthcare. And we need to continue to work towards improving pain and withdrawal management, especially when people are hospitalized. I also want to acknowledge that while I've been talking about safer supply programs and the urgency to scale them up, I'm also very aware of the fact that just like we cannot criminalize our way out of drug poisoning crisis and related social injustice, we also can't medicalize our way out of it. There is no way that the medical system can keep up with the demand for safer supply. So with this work, we are also responsible for demanding the defunding of policing and prisons and pushing for decriminalization of drugs. Without these two shifts in policy and politics, we will not be able to end the increasing rate of drug poisoning deaths that we're seeing today. Decriminalization and safer supply alone won't stop the number of deaths that are currently occurring. And 20 people dying every day in Canada is simply unacceptable. In order to change the trajectory of deaths, we need decriminalization, legalization, and regulation, similar to what we have with cannabis, but cannabis is not where we want to be either, because policies are making this expungement of criminal records of those who have been criminalized for simple possession cumbersome and very difficult to get. The current supply of street drugs is toxic. It is killing people, and prohibition is to blame. Just like what happened with alcohol when it was prohibited, we keep getting stronger and stronger products so that you get more for less. Opium to black tar heroin, white powdered heroin, fentanyl, carfentanil, and now benzodope. What we are witnessing is a supply-initiated change. Regardless of the preferences of people who use drugs, the changes are likely here to stay as long as drugs aren't legalized and regulated. And it is not only impacting people who use opioids, it's also impacting people who use all drugs. We need a safe supply of drugs so that people don't die. We need to regulate this market so that the drug supply is no longer under the authority of criminal organizations. And we need this safe supply of drugs to be available for people without a prescription. The role of drug choice and distribution needs to be put back into the hands of the people who use them. Thank you.
Nancy, thank you so much. The chat room is full. I've never seen so many emojis of clapping hands. And praise to you and thanks to you for not only sharing your story, but putting together a very comprehensive qualitative and quantitative approach to the subject area. And you've almost taken us up to the time for the next speaker. So all in all, full marks. Full are you that circumstances will change soon? I know we've talked about a sense of urgency here, and I made notes and acknowledged that progress to date has occurred. But what gives you hope as you look ahead?
What gives me hope? I heard one person that I spoke to, a person who uses drugs and speaks openly about their situation, said that they feel that finally they feel that they're being heard. And that gave me hope just hearing that people who use drugs are starting to be heard. They're not at all the right tables. They're not involved in all of the right conversations. But I think that people are starting to understand that that is crucial for any change to happen.
Wow. Well, thank you again. That's a lot to digest, and I hope you have an opportunity to go through the chat room and some of the comments. Your presentation was incredibly well received, and thank you very much again on behalf of everyone.
Thank you, Randy.
Well, that sets the stage for the next speaker. And Eric, not that the bar has been set inordinately high, but you got quite a
yeah. There's no way I'm going to follow
Oh.
that. I'm resigning.
Dr. Eric Weissman is next. He's going to be talking about housing is harm reduction. He appeared on CBC radio. We listened to him on CBC radio yesterday as he gave us a teaser of what we can expect today. Eric has been developing and applying a lived experience form of scholarship to the study of homelessness, housing, mental health, and substance use since he recovered from episodic homelessness and severe substance use disorder over 26 years ago. He is a member of the faculty at UNB in St. John, where he recently formed a visual ethnography lab. So today we get to learn more about that. And Eric, the floor is yours. Thank you.
I'm just going to share my screen. Thanks for having me. And Nancy, that was amazing. I'm so, every time I hear you speak, I learn even more than I had learned before. So I really appreciate it. Can you see my screen okay? I want to make sure that I'm doing this correctly. Yes, no?
Good.
Okay. I'm sorry. I'm back where I want to be. Right. So here we are at the 4th annual Harm Reduction. I'm very glad to have been asked to be part of this year. I've looked a little bit into the history of the symposium, and in this area, it has an incredible reputation, and it makes a great deal of sense because since moving here about 4 years ago, I've recognized that there's a lot of harm that needs to be reduced in this province in particular. I've lived all over Canada and the US, and everywhere I go, I see the same problems, and I hear the same difficulties that people have. And the reason I hear these stories is that I am also a person with lived experience. Before I did my PhD in 2009 to 13, I had drugged myself out of my PhD in 1988. So I'm what I call a lived experience scholar, and the photo up top is me all bright-eyed and really happy entering my MA, which was, you can tell by the dress, a very long time ago. And then a few years later, after my addictions had suddenly got a hold of me, weighing 128 pounds and entering homelessness for the first time. So I went to rehab. I'm about 26 and a half years sober now. And for me, abstinence wasn't really a possibility. At the nadir of my addictions, I was, I dissolved all the bone in my face from my teeth up to my septum. I have no septum as a result of, I used to, I was a cocaine head really, but I had OD'd 4 or 5 times on heroin. I got all my calories from alcohol. I drank 26 to 40 ounces of alcohol every day. I left my PhD literally to open up a gallery and a bar so I could live in that lifestyle. And at the end of my addictions, I slept on a pool table for 9 months before entering rehab. So I won't get into a really long discussion about my experience, but I will tell you that it was when I went to rehab for the second time, a very long-term rehab, that I was able to find a space, a safe space, and a place. I was there for 7 months. It was paid for by the government of Ontario. I had up to 2 years to recover at my own pace, and I did a lot of thinking about where my life had gone. I mean, to me, from my way of thinking, I was one of the easier cases of experiences of homelessness. Like for me, I came from a very good place. It wasn't a question of money. It wasn't a question of intergenerational poverty. For me, I was the case that everyone wants to say is the norm and is not. I was that person who became homeless because of addictions and just lost interest in himself and in paying bills and having work. And so for me, I don't think of myself as a really difficult scenario. It was pretty simple. I had to get control over my addictions and learn how to live my life again. And so I found a place that was able to help me do that. But I also, in that experience, developed a really important interest in understanding that the most shocking thing to me wasn't being an addict. It was losing the capacity to house myself. And so I went on, ultimately started working in Toronto with a bunch of people that I met on the streets who are also very homeless in 1996. And I say very homeless because there were different types of homelessness, and I'd never really thought of it before. You know, when I got back on the streets in 96, there were over 6,000 people living in different, living literally on the streets of Toronto, living in tents or under bridges. And I was hanging out with many of them. And one day I was led to a place called Tent City in Toronto, which was actually, there were no tents there. They were all small shacks built out of garbage that people who had been living on the streets for many years had built. And I got to know these folks, and it became quite a news story in Toronto. And many of you may know of it and might have read stories about it. But as much as the city of Toronto hated it, despised its being there, they held off evicting people who were living there. And so it started off as 6 little huts and ended up being 85 tiny homes of various kinds, again, built from garbage. And then one day the New York Times reported that a baby had been born there, and the public eye turned to that as a sign of great failure, and the mayor looked at that as just an image that Toronto couldn't sustain, and they evicted everybody in 2 hours. They literally sent down close to 300 security guards and construction teams, and they eliminated everyone altogether. So I followed my friends in that camp, in Tent City for quite a while. And that became the subject for a film that we worked on, a variety of different films that we worked on that looked at life in Tent City. And then, but 8 months after their eviction, they were given housing because there was so much public outcry about the evictions that the city of Toronto introduced the first rent supplements of the modern area, because there had been some in earlier periods in our history, and people who had been living on the streets, people who'd been in jail for much of their lives, many of whom had mental health and very serious substance use disorders, were given housing. And it was what we called the Tent City Housing Win, and I'll talk about that in a minute. And so we decided, since it was a collaborative film project, that we're not going to, it's not done. The story is really just beginning. It's really about what housing means, and what kind of effect can it have on people who have extremely difficult physical and mental health conditions. So it became the subject for, I had an opportunity. This is a great, the universe is sometimes quite mysterious, but in 2009, I was able to go back and do my PhD, and I wrote a dissertation on Dignity Village in Oregon, which was the first legal shanty town, which emerged at the same time Tent City did, but had a very different outcome. And I wrote about it, did very well with my dissertation, and converted it into this book that I'm showing you. And at the same time, I met a young scholar from the West Coast who was building tent camps in Oregon, or tiny homes in Oregon. Oregon has 7 or 8 legal tiny home villages, communities. And Andrew Heben is his name, and he wrote this book called Tent City Urbanism. And if any of you are interested in it, I would suggest looking at it. The reason I mention it is that for me, I just came to realize that it's not possible for people to deal with issues, whether they want to or not, or even to think about themselves without a stable base. So I argue, and I have argued for 20 years, and I continue to argue that housing is a form of harm reduction. And it's based on the statement that Barrick German made back in 1999, and again in 2005, when he was with the Toronto Disaster Relief Committee, that housing is a form of healthcare. So what I'm going to talk about very quickly today, because I want to show you a short film of a man who I met in Tent City, as he evolved and transitioned through housing is I want to talk about the notion of place attachment and place disruption. And others have spoke to this earlier, this notion of deserving and undeserving character. And the foundations of a holistic solution to the human condition. Because when we talk about harm reduction today, we're talking primarily about harms caused by drug use. But in fact, there are all kinds of harms that especially living in urban centers, cause. And housing has a central role in ameliorating all those kinds of harms. And that's something we learned doing our housing predator research in Toronto. So then I have to, I have I don't know, I have some notoriety as being an advocate of tiny homes and alternative types of housing. And I really got that from Franklin Delano Roosevelt, who said in his big speech during the Depression that the problems were so massive that the solutions required massive and bold experimentation. And I still believe that, and I know that our national housing strategy calls for experimentation. So most of my work, my dissertation, the book that I just showed you, they ask under what provisions can different types of housing be considered parts of our actual strategies for supplying housing. For example, under what provisions can tiny homes be considered parts of a housing first strategy? Because housing first has a very long, complicated history. It hasn't always looked the way that it does. And I'm a big supporter of housing first. And I've had a chance to study all kinds of different spaces. So I'm going to talk about them just now. One of the other things that I want people to think about is most of my advocate friends in the States now aren't talking about homelessness. They want to, language really matters. A lot of my work is conceptual. It's about words and language. How do we talk about things, right? What does community mean? What does community housing mean? The idea that people can have a home wherever they are housed seems to be emerging as a really dominant mantra in the States, especially because what people need are structures to live in. They need houses. And so there are a lot of, you'll start seeing the use of the term houselessness rather than homelessness, because COVID, for example, has proven to us that a lot of people are losing their houses, their apartments, their places to live, and they're having to make home in very difficult and tenuous spaces. So for me, the notion of deserving and undeserving character underlies all of our, similar to what Nancy said, we look at people, and I say we very loosely, but there's the law, and most of our policies are based on principles and laws that were brought over with the colonialists in 1601. And those are based on 1400 and 1500, the 1400s and 1500s, they're rooted in the Elizabethan Poor Laws. In fact, the language is almost the same if you look at the language of some of our laws on what vagrancy is, for example, and the Vagrancy Act, which existed until not too long ago. And so I think that when we think about who is deserving of assistance and not deserving of assistance, many of us may not understand that our attitudes that are handed down to us from generation to generation are ancient, archaic, and need to be rethought. In fact, there is no such thing as deserving and undeserving character necessarily, and that it's been not just and I agree that it's been what's the word, excessively applied to our Indigenous and racialized fellow citizens. But I also see it as a class issue. And having worked in many of the cities that I work in, it was one of the, this is a really bizarre, it's a catch-22. One of the strange things that unites people of different classes, settlers and Indigenous peoples, was when they get tossed aside and cast to the streets, and they finally understand that there's this larger system that loves to discriminate. And I think that most housing exclusive policies use class and race-based discrimination to control the supply of decent and affordable housing. I get angry when I listen to the news about how developers are finding it difficult to build affordable housing under the current circumstances. I think that that idea that profiting off of the instability of people is so normal is what's really wrong with access to housing in Canada and other places. And I think that what we need to do really is shift our perspective to accept the fact that, we didn't always have universal health care. In the 70s, we were granted universal health care. And we accept that now. And I think now that we've embraced housing as a human right by Canadian law, that in time that will come to be true. And the way to do that is to include a number of different types of housing, that some that are more conventional and some that are more what's the word? Progressive. So harm reduction and the harm principle often get confused as well. And this also muddles the discussion about what we're actually dealing with. And in law, the harm principle is the degree to which an action threatens a moral, economic standard or economic standard, or it contains violence, right? And it's another thing that we've inherited from 300 years of history. It's not the same thing as harm reduction. And so when I talk about harm reduction to people in the public, they often think about the lives of individuals who are using and might be living on the streets or living in what other people might consider to be dubious housing as an infraction of the law. And they see the deserving nature of people in terms of the harm principle, not the harm, this broader sense of harm, which refers to policies, programs, and practices that would perhaps minimize the negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. In other words, people see individuals who might be using drugs as less than. And I love telling people my story because it kind of makes them go, what? I wouldn't get that from you. And I go, well, this is the whole point. This is why we need to change our discussion on what these things mean. So the harm principle is a legal and ethical precept. It's not what we mean when we talk about harm reduction. And I think that's really, believe it or not, in trying to make harm reduction more acceptable across the country, we need to be quite clear about what the difference between the harm principle and harm reduction really is. So because they're often confused, it's easy for people to continue to maintain the myth of the undeserving nature of individuals and to have very little faith in that they might be able to change if they want to change. And one of the things that I found in all of the work that I've done in different places is that as soon as people are given stable housing or housing, even if it's transitional housing, there are immediate effects on the psychology of the individual, which lead to ancillary and very fundamental impacts on their health, especially their mental health. So to me, it's all the reason that happens is because we have a moment where people are able to attach to place. Edward Casey was an important philosopher, and he said that the essence of human culture and human civilization isn't about the size of things or where things are located. It's what humans bring to spaces. It's the creative moment where an individual attaches to a space and makes it their own, or where a community forms with other people. And so forming an attachment to place is personal and social, and it's those things that being homeless or very often being a person who's experiencing homelessness and addictions like I did loses. And Julia Woodhull-Melnick, who's a colleague of mine, did some great research on the flooding here in New Brunswick, and I think about it because we talked about place attachment a fair bit. We asked, why do people stay in places that are going to sink? Every year they get washed away, and people stay because it's their home, because they have a connection, and in that connection their identity is wrapped up in that place, and it's a tie to ancestors. It's not something that you can quantify. It's not something that you can see or feel without looking at its representation, the artifacts. The board that an uncle used to mend a wall in 1965. I mean, there are meanings that are important to understanding the human experience that aren't necessarily empirically measurable without a very deep kind of approach, which is why I've chosen in my work to look at things in smaller pieces, very visually, and to try to understand what things mean to people who are in those situations. So a connection to place is vital to human society, and it's wrapped up in what we call social imaginaries, which is the way people see the world, what should or shouldn't be, what is proper housing, what's improper housing. And the truth is that people, when they see things enough, can change their social imaginaries. I mean, they can have a change, sometimes we call it a change of heart, but really it's a change of vision. And so very often, there's a debate about what constitutes appropriate housing. And this is one of the problems I have in my work, and trying to explain to people who don't see tiny homes, for example, as places where people could form a proper attachment to place. I worked with Jesse a little bit on this, his definition of Indigenous homelessness. And the reason I like it is that it tries to expand our sense of connection far beyond the conventional connection to place, which is an individual in a space. Whereas his definition of disconnection, homelessness, is the interruption of individuals, families, and communities who are isolated from their relationships to land, water, place, family, kin, each other, animals, cultures, languages, and identities. And so that's why, to me, if we're willing to embrace that as the definition of disaffiliation, which, by the way, was the term used to describe homelessness until about the 1950s, if we're able to accept that, then we're able to see how different kinds of spaces can actually provide for restoring those kinds of connections for people. So it's the attachment to place and to people that is absolutely key. And to me, we know that many of, we're all familiar with the drug experiments where lab rats do drugs, and then under social conditions, when other lab rats are introduced, stop doing them as much. And we also understand, for the most part, the biochemistry, that certain drugs affect our pleasure centers the same way that social activity and social interaction does. So we know that there are interconnections between drugs work because our bodies are designed to facilitate the mechanics of those drugs, or the physiology. Our physiology is affected by those drugs, and so are in some ways our brain and our feelings and emotions are affected by our relationships and our social experiences. So I think what I would like to argue is that harm reduction requires us to rethink what harm actually means and what substances actually look like, and to embrace different visions of place. I mean, some substances that we take on a daily basis, like sugar, are worse for us than some other drugs might be for people who take some of the illicit drugs that people are taking. And I don't want to make this argument. I had a student recently who wrote a paper. It was quite interesting, and they explained the extreme cost to the healthcare system and the loss of life caused by alcohol and tobacco. And I completely agreed with them. And they said, but aren't these monitored drugs? I mean, aren't bars? Can't we think of bars as places of managed alcohol consumption? And I agree with them entirely. So my feeling was that, if we can change the ideas around the use of materials, then we can change the ideas. I mean, if we can say that it's okay to sell cigarettes and liquor, then really the argument is a social one, not a physiological or medical one. So what is the how do you bring housing into that equation? How do I argue to people that, well, that's true, and one of the ways to minimize the chemical impact of a drug is to add another variable, which is stable housing. Because when people have stable housing, they tend not to engage in those materials as much. And one of the important things that I found in all of my work in some of these in tiny home villages and in Housing First projects where people had mental health and addiction issues, was that drugs themselves have a certain form of currency. They're a part of the social and cultural economies. And so, in the absence of meaningful connections, or in places and cases where people need to find a place to sleep and drugs will get them that, the drug use is higher. And I was one of those people. For the last 5 years of my addictions, I traded drugs almost every night to find a place to sleep. And so it's another issue that people don't often think about. So housing is healthcare, and healthy lives start at home. 235,000 people a year are considered homeless in Canada, and we know on the streets, those of us who do the work know that this is probably a much higher number. We don't really know how many. We have a much broader definition of homelessness now. So when we're talking about people being homeless, if you think about couch surfing and sleeping at someone else's place as normal, then the number is lower. But the definition of homelessness that I use, the Canadian Observatory on Homelessness definition, includes that as a form of homelessness. So, for example, in Oregon, when I did my research, they said that about 3,500 people were homeless, and that meant literally homeless on the streets of Portland, Oregon. But the Department of Education, because it uses a different definition, said over 16,000 people were homeless, and most of those were children because they were sleeping at a friend's place or on a couch. So depending on your definition, the housing itself the definition of housing or home, it varies from jurisdiction to jurisdiction. Yeah, all I can tell you for a fact is that every city in Canada, people are dying on the streets. And in Toronto, I'm from Toronto, we have the Toronto Homeless Memorial, and the numbers of people dying on the streets is increasing, not decreasing. The bottom line to me, and this is a picture of a woman sitting in front of her home in Dignity Village, is that housing is key to healthcare. It's key to reducing all forms of harm, and safe, stable, and attainable housing also has long-term effects. It can reduce the impact of addictions, PTSD. It almost eliminates criminalization, persecution, and so on. And it does that by creating communities where drug use is actually okay. And I don't mean that it's preferred. It's not like, yeah, you can be part of this community if you use drugs, but if you come to this community, you won't be prosecuted for using them. And Dignity Village was like that. So the cost of not providing housing in Canada, just so you know, is about $54,000 per person who's experiencing homelessness that might be related to drug use. And I've given you the link if you'd like to check out the link. The cost of not helping someone is about $53,000. The cost of helping someone, providing housing, usually housing under the Housing First model, is between $11,000 and $23,000 per person. And that's just the facts. So even if you're opposed to these to help providing people housing, regardless of what style of housing you prefer, people live longer, live better, and it costs less to provide housing. That's just the bottom line. It's irrefutable. So my question is, what kind of housing? And certainly not this kind of housing. This is Jay, who lived in a tunnel underneath the Air National Guard in Portland, Oregon. His wife lived in Dignity Village, a few hundred yards away. He had been kicked out of the village and was forced to live under the culvert. And he said, "Oh, I've lived under culvert for years. This doesn't really bother me at all." The space itself didn't bother him at all. So one of the first things that I was interested in, like I mentioned to you, was grassroots tiny home communities. I call them intentional homeless communities. So after doing all this research in Toronto and other cities, I went to Dignity Village and I stayed there for several months and studied life in the village. You know, as a villager, lived in a shack, and I called them shanties back then. And since then, I've changed my language. That was back in 2010 and 2011. But the amazing thing about Dignity Village was that it was a political claim. It disturbed the city so much that they took them to court, and the nonprofit, these activists won in the state constitution because they had the right under the law to build an emergency campground, and this became it. And every house that you see in these photographs was built from scrap for nothing. Frankly, the city gave them this piece of land, and the average cost to live there for each person at that time was $2.34 a night. My first book was about Dignity Village, and I asked Nigel Dixon to come take pictures of people in their homes. And what you realize when you look at these places and these spaces is, and to me, my book was very critical of the village. In fact, since in the years since, we've gone on to correct the things that were wrong with it. But this is a village without any resources, no city money, no funding whatsoever. People who traded sweat equity for membership and might have had very low paying jobs, but all of them called this home. All of them, their health improved immediately after coming off the streets and moving into these small shelters. And we can talk about that at more length if you'd like to. Just contact me and I'll share all kinds of information with you. At the same time, an emergency rest area was being built in Portland, Oregon, called Right to Dream 2. And they managed to get this piece of land at the foot of the business district for $1 a year because the landlord had a grievance with the city, and they told them what they wanted to do. You know, one of the things that was killing, and don't forget, Portland, Oregon is a small place. It had, at the time, 590,000 people, but 3,000 people were on the streets, literally. And that's a very high number for a population that small, and they were dying. People were dying. So the same group that opened Dignity Village opened this, what they call an emergency rest area. They're not called a tent camp. That's illegal. They're not called a tent city. That's illegal by the law. And so they were taken to court. They tried to evict them, and the Oregon State legislature wrote new legal language and called them an emergency rest area, which are now legal in Oregon, which is why there are more than there were at the time. Since then, they reached a settlement with the city. The city gave them $1 million worth of housing, and they now are called Right to Dream 2, and they have a tiny home community just on the other side of the river. But it is estimated that they saved over 10,000 lives in the time that they were there, because over 35,000 people per year would use the services of the camp. So these, I don't really want to see people having to live in these places, but they served a certain purpose. This particular camp model on its own was actually funded, and nonprofits would come and bring food and mobile showers. And so when they moved into their, they didn't really want to move into their permanent tiny home settlements, but they did save lives, and they did provide, because they felt that if they were moved from their street ministry, that more people would suffer. So this is a little bit more about Right to Dream 2, and you can find them just by Googling Right to Dream 2 on Portland, Oregon. At the same time, the city of Oregon built a housing first model called Bud Clark Commons on the left. And this is a model of housing first in Helsinki. And what I always found interesting, and I wrote about it in that last book, was that when I was in Right to Dream 2 the last time, a young woman died and the ambulances came, and they were talking about she died from an OD, and they were talking about the OD that happened at the Bud Clark Commons, which is a fully supported housing first community. And it just became clear to me that there is no real what's the word, one size fits all solution, that the way of reducing harm caused by long periods of incarceration and life on the streets is wild and ambitious experimentation with different forms of housing. So the cost for housing first, like I mentioned before, was if you leave people on the streets, as I mentioned earlier, the cost can be as high as $50,000 to $60,000, depending on where it is for medical and other reasons. The housing first model generally per person is between $14,000 to $22,000 per person. And I got this information from the Nanaimo Homeless Coalition. Just by looking at this, you can see that it makes a great deal of sense to limit the amount of money, to limit the kinds of investments we're making, and that housing first is one of the most successful models that we have. So another interesting study that I did that I worked on was at the Wellesley Central Residences in Toronto. This is a place, it's a harm reduction model. It's based on housing first principles, where people pay a certain percentage of their income, and it has people who are living with HIV/AIDS and people who are frail elderly individuals. And the reason that it's initially a co-residence, but they have full supports on the premises as well for individuals. So one of the important issues that they dealt with there was the problem with stigma in the neighborhood, and the fact that they've been very good members of the community and do a lot of outreach has really helped them. So there are all kinds of types of housing that are proven to improve health outcomes. And I would argue that tent camps, as awful as they seem, provide a very short-term emergency type of assistance to people who need it. There are rest areas where people, like R2D2, where people can go for 24 hours. There are the grassroots tiny home communities, like Homes for Heroes in Calgary. And there are organized and funded tiny home villages, like the ones that I've been showing you, like Dignity Village, and many others now, which are developed. Marcel Lebrun has his community that's in Fredericton right now, the 12 Neighbors, which is really kind of interesting. And then there are regular market units and housing first supports and continuum of care programs. All of these different types of housing are basically based on essential different principles, but provide necessary care for people. So I'm going to share a video with you momentarily. This is a story of Brian Dodge, who had lived in Tent City in Toronto and who would be given housing. And it shows the amazing ameliorative effect of someone with deep concerns and deep troubles after they get housing. So I'm going to, hopefully this will work.
Hello. Smells the same? Is trailer housing? Where's trailer housing smell like?
Remember that building up on Martin Grove?
Yeah. Yeah. Willow Ridge. Yeah. Willow Ridge.
That was a pretty frightening experience, wasn't
I'm glad I'm down here instead of way up
it?
there.
So, Brian, have you had any follow-ups on your cancer treatment?
Yeah, I'm okay.
What did they say?
I'm okay, clear. All clear, my doctor said. He gave me a good bill of health. A1 health.
Does it bother you that you're still smoking?
No, it bothers him, not bother me.
What does he say?
He says, how you still smoking? I said, well, of course, you should know that, Dr. Washington. How long have you known me? 10 years? Ready?
No. No.
They look scary. See, that's why I couldn't have one of these things. It'd drive me cuckoo. I'd throw it over the balcony.
Why?
I don't like it. Anything hard to get through my head. I can't. Why
I
is
think
it?
it would have to be hard to get through your head.
Oh, and these things. Oh, I want to throw that thing over the balcony sometimes. How are you? How you been doing?
What's happening, bud?
Not much, you?
Not much. Let me see your scar. Jesus.
Twice.
And that's where they took the stuff out?
Yeah.
And how are you feeling? Not much. Let me see your scar. So how do you feel, Brian, when you see yourself? Jesus.
Okay, I'm okay with it.
Can you tell me a little more?
Look at that though. That's I could not know. That looked ugly. That all it did, that only looked ugly. That's where I was shot.
What did they say? That's where you were shot?
That's where I told people that's where I was shot.
You had lung cancer, you said.
I know. But I told people I was shot there. And they believed me.
How much of your life is fantasy, Brian?
My whole life is fantasy, a fantasy world. My whole life is a fantasy world. I've done too much.
Let's just say,
Done too much, way too much. No, it's not a fantasy. It's not a
That's where
fantasy.
you had lung cancer,
Yeah.
not where you were shot.
No. No, that's what I just told people. They what? They were shot. They were
This
shot.
is the dragon.
Dragon.
And hold on a second. And what does the dragon mean?
What's the dragon mean?
Don't move. I just got it in the frame. What does the dragon mean?
Dragon. It's just a dragon, but I had to tie it off here and tie it off there and tattoo it myself.
In the joint?
Yeah.
How'd you get the colors?
China ink. Believe me, it's scary. I tell you, Eric, you know yourself. I lived in Tent City. I've been through a lot in my life, okay? I've been seen knives pulled on me, I had guns pulled on me. I've fought, I've been knocked out, I've won, I've lost, but never scared me till cancer. I was terrified.
You've pulled a few guns, haven't you?
Yeah, and I've been terrified.
Like
That's a bad boy.
So what happened?
Well, I kidnapped, you can go check, in Ottawa.
You know what? I don't have to.
I kidnapped the police in Ottawa.
What?
I had them all chasing me. I had one cop beside me here, right here, he's driving. As you get on that phone, you tell him back off. No secret, or family jewels are going.
Do you remember our last interview, last 17 interviews?
Oh yeah.
And you never mentioned any of this.
Oh no. I keep a lot to myself.
Okay, well,
tell me about that one.
Well, we're in the movies.
All these things you leave out, man.
Just minor details,
Just
Eric.
minor details.
That's the best part to leave them out, because I don't want people running away from me. Because I've changed. I don't know if I changed for the good or the worse.
If I take you back, like we're going back now, and you look at this video of all the places we've been together, and to me, these are, I call originating moments. These actually happened between you and I, and a lot of these you've forgotten. But when you look at these moments, are you taken back to them, or do you have memories of them that you now have to replace?
Oh, I gotta replace them all.
Because you remember it differently than what you're saying.
Yeah.
Is that true? All of it, or
Yeah.
just some of it?
Some of it, like See, there's a lot of places I don't even want to remember about. I blanked them out of my mind.
Okay, but back then you guys never wanted to see yourselves.
No.
You wanted yourselves to be captured and you wanted something to be done with it, but you didn't really want to look at yourselves.
No, we didn't. Because it was on the crack cocaine. Crack cocaine. See, when you're on crack cocaine like that, you don't want to see that. You know?
Even if I want to say I've told the whole truth, I never really know the whole truth.
No, you never really do.
So the only truth that I know is the truth. The truth
that,
I know is the only truth I can tell.
Yeah, exactly. Exactly. Like this, it's here. You know that's true. So you know that's true.
And did I tell this fairly? I didn't need to talk about it. It's self-explanatory.
Self-explanatory, yeah. That's when I got my certificate for going to church, entering the church.
It was a big day for you.
That was a big day for me, yeah. I'm just saying, we're like to thank Sandra and Jeff for all the years they've been stuck in with me and Eric through the hard times. It's not right for time to talk.
What does God mean to you?
Peace of mind. Peace of mind. Peace of mind.
How does that work out?
How does that work out? You have peace of mind.
Don't you think this is how our connection to other things are? They're always there, but they're not always.
We don't really see them.
Right.
We really don't see them until we run into somebody that we know from a long time, and then, boom, where you see this. Okay? Then reality will come back.
And so I guess the question is it real?
Yes, real.
So the reason that I often show Brian's story is that his transition was really quite amazing, and others that he lived in Tent City with had, by the way, 3 of them, including Eddie Johnston, who's a very famous for his role during the Kingston riots. He actually was living in Tent City at the same time, and what was amazing to me was it showed that how these different spaces fulfill different needs at different times, and that how the harms. To understand harm and harm reduction you can't study it in a static way. Like you have to look at it in terms of the transitional experience that reducing harm produces. And so, when they were living on the streets and living under the train bridges in Toronto, things were really rough. And then they found Tent City and they moved into Tent City and they had some housing. They were able to build housing in communities, and some of their parts of their lives got better, and then they were evicted and they got housing and they got supports, and there's this incredible progression of harm reduction, the harm of having lived the lives that they lived, having experienced the traumas that they had lived. And so even people with extremely complex comorbidities and substance use disorders can benefit from housing, and different kinds of housing will answer the question, right? For different people. And while Dignity Village, is a rather crude example. Since Dignity Village started its battle for legitimacy, hundreds of cities have now put millions of dollars into building tiny home communities. And whether people want to see tiny homes or not is not really important, because they're part of the continuum of housing that can help people through their even tent cities serve a vital role given the context that we live in, where people are out of the streets, where shelters are full. So my interest has always been to understand the way that different forms of housing can fit into our solutions. Now, I don't obviously see tent camps as a solution, but I do see them as part of the progress that we're making towards solutions. Tiny homes, secondary units, apartments, housing first projects are better places to live, and people must have places to live. So some of the observations that I'd like to suggest, and if you'd like to watch the entire film, I'll provide you the link at the end of this, is that supports and community engagement are needed for long-term success. That learning how to manage a home and keep it is one of the hardest things for newcomers to do. And there's an entire list of things that people need to do. You know, people that I met who were living in these tiny homes and who were experiencing different degrees of homelessness and degrees of addiction required different solutions. So it was interesting because when people moved from their tiny homes in Toronto to the apartments that they got, there were different ways of understanding what success was. And Kathy Crow, who you might know is an important, she's a nurse and an advocate. Actually, she and the Toronto Disaster Relief Committee managed Tent City. That she said that it's not important what they succeed at or not when they're in Tent City or even in housing. It's true that people reconnected with family, went back to school, got jobs, and they kept their housing. But what really matters is, and this was true of Tent City, is that people managed to stay alive and their health improved. They didn't die. And even in Tent City, which was a crude place, that minimal amount of housing was enough to help people who most likely would have perished or become extremely ill on the streets of Toronto at a time when the streets were overrun. So one of the questions that Barrick German asked, who was one of the founders of the TDRC, is that all we want from a person, whether they're an addict or not? Which is why I've always talked about housing as low barrier, and that public housing, for example, so-called public housing that has restrictions on what people do in their units is really problematic, which is why I like the tiny home model. Because for example, Dignity Village, each of those homes is considered a self-contained unit, and what people do in the privacy of their own home is protected under the law. So if people, you know, I don't believe that you can have people managing addictions, or if you want people even to think about getting off of addictions, they can't do it without a home. You can't have somebody trying to control their mental health from obscurity. So if you want people to get better, or you want to get better, they're not going to get better on the streets. So we can all act together to get people homes. And that's why, to me, housing is a form of healthcare. There's no question that it is. And then if you watch the longer version of Ethical Traces, which will be available on these slides, it talks about different examples of this. In fact, I was watching a bunch of different movies. The original subtext version that I did is available on this list, and there are other films that show just how people's relationship to housing is complex. It's not simple. One form is not better than others, and how even forms. I mean, I'm very happy to have a home. I bought my first home in my life at the age of 60. Because of how precarious my life had been, and I'm enjoying it. But I'm beginning to understand why some people can't handle this kind of existence. So I recommend to people that they view these films that I've suggested on this list. And one of them is called Shelter from the Storm, made by Michael Connolly, about the role that Kathy Crow has played in the city of Toronto. I think the real comment that I wanted to make most was that you can't ask people to address their needs, and you can't ask a society to address its needs to help people with mental health or addictions from obscurity and from the survival anxieties that are necessarily born of the shelter system, life on the streets. You know, we did some really interesting research, and we're in the middle of it now, actually doing more of it on post-secondary student homelessness. And it was a horrible finding in our original study to find out that many young students were staying in abusive lives or getting involved in the sex trade in order to have housing. You know, you keep seeing stories in the paper about students living in their cars to get through their undergraduate degrees. And so to me, the idea is that housing itself is like, there's no way to reduce harm of any kind unless people have stable and safe housing. And so I like to argue, and I hope this has conjured up some questions for people about what constitutes safe housing. The truth is that even tent camps provide some degree of safety for people. And ultimately, I would like to see people living in things like these progressive, supportive housing first communities, if that's what they choose. And that's about it. I don't know. Hopefully there'll be some questions I could answer.
And there may be, Eric, but right now we're right on time.
Oh, sorry.
And we're going to take a short break before we come back to have a panel discuss something pretty important. It would be tone deaf for us to ignore COVID and harm reduction. And we've assembled a panel that at 3 o'clock will start to unpack some of these issues for us. So let's stand adjourned for 15 minutes. Let's take a bit of a bio break and reconvene at 3 o'clock. Thank you.
I
all.
always take too long. I'm sorry.
Not a problem, Eric. It was great. Welcome back, everyone. And thank you for sticking with us. It's been quite a day so far, and we're going to carry on and I think have a panel discussion that I think will be quite informative and helpful for us as we try to get past COVID or adapt to it or reflect on what that really means for harm reduction and the work that we've done. Frontline service providers have operated under stressful circumstances. It seems certain that many are burned out. And to talk about that today, we are joined by 3 individuals who know what they're talking about. Ashley Doran is a registered nurse who has worked at the St. John Correctional Center since 2018. She is joined by Dr. Tracy Meyer, an emergency physician in St. John. Dr. Meyer is an advocate for harm reduction throughout Horizon Health Network. And joining us from Calgary, where it finally is afternoon now, is Jeanette Wagemaker-Schiff. Her current research includes the psychosocial needs of staff in services for homeless people. We'll be pleased to welcome Dr. Schiff to New Brunswick next month as she will address the Community Advisory Board gathering in Moncton of homelessness surveying agencies and supporters in Moncton, Fredericton, and St. John. But I think I'd like to start by putting to the panel a question. How has vicarious trauma or burnout affected the ability to practice harm reduction? And if I could, I'm not sure if the 3 have determined a speaking order or not, but perhaps we could I could throw that out to Jeanette, our guest from Calgary first.
Thank you so much, Randy. That's very kind of you. I'd like to perhaps address the question first about all by saying that we're not talking about burnout. Okay, we are talking about people having an inordinately high level of traumatic stress. And so in the national study that we conducted across shelters across 7 different cities across the country, including 3 in New Brunswick, we found that burnout was at a low moderate level, but traumatic stress was at an extremely high level. So if we can correctly identify what we're talking about, and the importance of that is, and I think it's really relevant to everyone who is here at the symposium today, is that people continue to care. When you're burned out, you kind of get disengaged, you check out, you no longer care. But when you're stressed out, the dilemma is that you care, but you can't. And it creates a horrible quandary for workers on the front line who are so emotionally fragmented at this time. And COVID has really exacerbated this inordinately, so that we've all felt it a great deal. The other thing to add to that is that we're really talking about not only, quote, the vicarious traumatization, the way you're impacted by what you hear from your clients, but you're also directly traumatized by what you witness every day. So that the real impact for frontline workers is also, as we've heard from so many wonderful presentations throughout the day, it's what people are witnessing and part of every day, not just what they're hearing about on the sidelines. So I think it's important that we recognize that during COVID, everything has been thrown, as we all know, through a loop, but we've now got the numbers that also support that. I'd like to invite other people on the panel to join me on this as well.
So thank you, Jeanette, for saying that so articulately. And I can definitely add some personal things. I don't think I can actually quite say it quite as well as you did, but I think one of the biggest issues and one of the biggest causes of burnout is actually a desensitization that comes out of pure self-preservation. So when you're constantly seeing awful situations, awful traumas, there comes a point where if you don't let yourself desensitize to a component, it hurts too much. And that's where burnout really initially comes from. And so we see that all the time in healthcare. And I suspect that, yes, COVID has contributed quite dramatically to that. And then the other issue that I'm seeing a lot in both the emergency department, but also in harm reduction clinics is, and this is perhaps it's more so within the emergency department, but there's a treatment of healthcare workers that we haven't had before. And it's something that has come out of COVID, where I would say 90% of the people are still wonderful people and wonderful patients. But there is a treatment that has occurred during this pandemic that has become very harmful. It's difficult to continue being, you know, I don't want to say caring, but it's difficult to go into work every day with a smile on your face when you're being abused. And so I would say for a lot of healthcare workers, there's a component of abuse that has been happening more recently, particularly within the emergency departments, that has made sometimes our own emotions are higher and more strained than normal. And then that also makes it more difficult to be compassionate to others. And so, and we're seeing a lot of that, but at the same time, I do think that it's also been a time where healthcare workers have been trying really hard to collaborate, come together. And along with that, there's been a lot of talk about resiliency, but a lot of the resiliency has to do with just having that collaboration with each other and also remembering where the actual focus should be. So it is definitely a very challenging subject.
Yeah, I definitely have to agree with Dr. Myers, and I know from my personal experience here, there's a lot of suspicion and a lot of hesitation when we, roll out these COVID policies and procedures. And from past experiences, these individuals, their encounters with healthcare providers in the past and their reluctance to kind of accept like what's out there. There's a lot of myths and fallacies associated with COVID. So on our part, like it was a double, you have this increased workload and you're trying to provide for your clients, and at the same time, they're reluctant to accept what you're offering because of all the myths and misinformation that's out there about COVID.
Thank you. Can we unpack that a bit more, Jeanette? Could you tell us about some of the work that you're doing or the research that you have undertaken, and if we can relate this back to harm reduction and COVID? What you spoke of the national study. What are your findings emerging from that one?
Well, I thank you for that, Randy. I'd like to talk about two things. First of all, the national study a little bit, and second of all, an additional local study that I've been doing with one of the emergency shelters here in Calgary that really has been eye-opening in some ways as well. But anyway, in terms of the national study, we wanted to look at the extent to which frontline workers were experiencing either burnout, vicarious traumatization, or direct primary traumatic stress, and the extent to which they continue to have or show depletion of what we call compassion satisfaction. That is, the people remain engaged in this kind of work, which is extremely difficult, trying, emotionally and physically demanding work, because they receive inherently some satisfaction in the process of helping others. And we find that during COVID, people continue to want to help. And I appreciate and recognize and so sympathize with what Tracy was talking about, the struggles, especially for healthcare workers in emergency departments during this period of time. But my research, which was really focused on the frontline shelter workers, who are often involved in harm reduction in many unseen ways, were experiencing these stressors during COVID. And we found that the traumatic stress went up. But I think part of it was also related to a pervasive traumatic stress that we all have felt during COVID. The kind of stress that is precipitated by events that are beyond our control, by being told what to do, where to do it, to having our own mobility regulated, that to create to a sense of not being in control of our own lives in the same degree that we would really want to be. So that's the kind of stress that I'm talking about. But let me flip for a minute and talk about the experiences at the Calgary Drop-In Center, which experienced a tenfold increase in opioid overdoses on site between 2018 and 2021. What I'm talking about now, the Calgary Drop-In Center houses between 800 and 1,000 individuals on any given day. During COVID, they have had to reduce their occupancy within one building and actually rent out some additional spaces so they could continue to provide emergency shelter. They started in 2018 with 18 on-site overdoses in the year. We're talking about a definition of an overdose as when a staff member finds that an individual is unconscious and needs emergency resuscitation, and then EMTs have to be called for transport to hospital. That figure of 70 went to 735 by the end of 2021, so 4 months ago. And in the first 2 months of this year, there've been an average of 300 overdoses per month. So it's escalated exponentially. The stress that this creates on staff is absolutely inordinate, because we know from my research that a lot of staff have minimal training before they enter the workforce, and their supervision, even after they enter the workforce, is coming from people who have been usually promoted because of their longevity rather than because they have additional expertise. So you do have a lot of challenges within the sector. So in terms of a harm reduction, there is a harm reduction that is taking place in these shelters, because I mentioned these numbers of 70 and 735, but out of the 735 resuscitations, I believe that there were only 10 deaths that were reported. So there is a huge saving of lives that's going on. But what's really happened is that, at least in Alberta, with our current rather restrictive government, is that they're unwilling to consider shelters as harm reduction sites. And so there's no supervised consumption that is possible within these sites, even though we know that a great many of the people who are using the shelters need safe consumption sites in order to prevent further overdoses. So we've got this huge quandary going on. And my concern is both for the victims of this restrictive government policy as both the clients and the staff. I should stop talking, give someone else a chance.
No, thank you. That was very helpful. Already we have a question in for Dr. Myers, and the question is, the increase in poor treatment towards ER staff coming from people who use substances. Is it the family of admitted patients unable to enter, or any specific group? What is your theory for this increase in violence against healthcare workers that is occurring alongside the pandemic?
So I think there's a lot of different possibilities there, and I think everything that you kind of mentioned is perhaps contributing. I think one of the biggest components is actually a mistrust of healthcare workers that's kind of been propagated by some of the thought processes of more fringe thoughts, but definitely there's been situations where people are mistrustful of the diagnosis of COVID. They're distrustful of the policies that the hospital's been putting up. So absolutely, there's a lot of restrictions around who can enter, policies of who can have people with them. And it just creates a situation where all of a sudden you're policing so much more than just health. You're suddenly there saying, no, you can't have family, you can't have items brought in for you. And that's not really a position that anyone in healthcare has usually been put into, that position of having to say things like that, or telling people that no, they're not allowed to leave their homes because they now have this new diagnosis. And these are not things that healthcare workers typically need to tell anyone. I wouldn't say in particular it's people who use substances. And as a matter of fact, I work in the emergency department. I also do have an opioid agonist therapy clinic. And I would say the patients at the clinic have been, there's been really no change in their behavior, and they've been just as lovely as normal. And in fact, they're actually, at times I felt like they actually were looking forward to the appointments, just to have the social interactions. So it's full variety, definitely. But what it has created is, within healthcare workers, perhaps shorter fuses than normal. And unfortunately, oftentimes when you're working with people who use substances, you have to come at the interaction from a point of understanding, a point of compassion. And when, in general, the compassion and the understanding is at a low because of fatigue, compassion fatigue, it creates interactions that are not always as helpful as they should be. And so I would say it's twofold. It's a lot of times the interactions are, everything's two-way. And so people push back what they get. So oftentimes if a healthcare worker is already fatigued and tired and not as compassionate or as kind as they should be, you're going to be presented with the exact same response from the patient. And so it's not necessarily even the patients or the people coming into the department that are the cause of it. Sometimes it's probably our own actual behavior towards the patients that create some of the difficulties. So I think there's a lot of factors.
Are there any particular barriers in particular you can comment on that COVID presented in terms of harm reduction efforts? And I would just toss that out generally. That's as a question to panelists.
Well, I'll speak to that one in a few different ways. So from the emergency department point of view, I actually saw more frostbite, more hypothermia this winter than I've seen at any point in my career. And it was interesting because I think the cause of that was due to policies that were actually very well intentioned. And it goes to the situation of shelters. And what had happened was there was this policy that if a patient, or sorry, I shouldn't say, if a person was diagnosed with COVID and was put into a COVID shelter, they were guaranteed that they would not lose their bed at the original shelter. And what that meant was all of a sudden a single person was taking up 2 publicly funded beds in shelters. And all of a sudden there was all these physical beds that had no people in them and all these people that had no beds. And so there were awful storms where people were being turned away from shelters that were half full because the shelters were not being permitted to actually use their physical beds for the people that were knocking at the doors. And so we actually saw quite a few instances of pretty significant trauma, significant hypothermia, and amputations from the frostbite as a result of these policies. So that was really upsetting. The other aspect that we saw quite a bit of was just issues around funding for medications. So I had a number of patients in my clinic who had problems with getting their publicly funded drug plans canceled due to the fact that they took on CERB for a while and it altered so I think there was a lot of confusion around how to access different funding, and it really affected their actual insurances. I had a few patients who lost their jobs and they were put into this difficult time period of not having health insurance. And so a lot of patients lost their funding for their opioid agonist therapy, which was, I think, really it was incredibly, I lost a few patients to where they stopped taking their medications. They've since come back, but it has been very difficult for them to be restabilized. Nancy, I think, oh, yeah, it's taken care of.
I'm just jumping in at Sarah. Hey, everybody. There's a couple of questions in the Q&A, and I wonder, one for Jeanette from Julia Woodall. I wonder if it's possible that the finding of traumatic stress in the St. John nonprofit workforce may be population related. We have a lot of folks in St. John who grew up in poverty and under difficult living circumstances. We see many folks looking to give back through employment in the nonprofit sector. Were you able to control for socioeconomic backgrounds or experiences of ACEs, adverse childhood experiences, in the workers' lives?
Actually, thank you for that question. That helps me to clarify things a little bit. Yes, we actually asked about adverse childhood experiences. We asked about lived experiences with traumatic events outside of work, but we also asked about people's experiences with experiences of traumatic events as part of their job. And one of the things that we found, first of all, was that St. John, Moncton, Fredericton are not much different than the rest of Canada in terms of the people reporting ACEs. We did not ask about childhood poverty, but we certainly asked about adverse childhood experiences. We asked about resilience. And so we tried to cover as many bases as we could without making people feel as though they were being surveyed to death, so to speak. I can quite clearly say that we can rule out adverse childhood experiences as being a significant contributor to the traumatic stress that people have expressed. What I can also add, and this is something that was interesting and it was totally unexpected, it was the opposite of we expected, that actually shelter workers who were working face to face with clients were reporting lower rates of stress than people who were working from home. So case workers, outreach workers who were not required to be on the floor all the time and who were working remotely and making plans to connect with clients either remotely or by meeting with them in public places because they did need to have some contact. Those workers were actually experiencing greater levels of stress. We speculate that that's because they were lacking the social component that goes along with just being able to get the support from your peers as you're working alongside during difficult times. It doesn't make the difficulty go away, but it helps to know that you're all on the same boat. So those were some really interesting findings. I don't know whether that answers the question or if there's a follow-up question to that I can help to clarify it.
Julia can pipe up, but I think that does answer the question. And to the entire panel, there's actually another question that I'm really interested. I just listened to a podcast on this the other day, actually, and that's the concept of vicarious trauma. And the question that, does it suggest that workers are traumatized by the experiences of people they work with? And can the panel clarify the term a bit more? Because does it paint individuals in needs of services in a negative light, or does it stigmatize them that now they're causing trauma to us, say, or to the workers that they deal with, rather than as folks who are accessing the service and they need it? So now are we blaming them for doing harm to us, I guess?
The thing that we have to remember is that our clients come with histories of trauma. And that we also know that workers come with their own personal experiences of trauma. And in addition to that, 55% of all of the people that we surveyed, and we surveyed about 574 people across the country, so it's a fairly large group, 55% of them that report that this is part of their job. And this is a fact that has received virtually no attention previously, and that is a recognition that that people who are working frontline, and we did not specifically survey people who were just working harm reduction services, but shelters are hopefully harm reduction environments to some degree. So we know that 55% of people are reporting that traumatic events are part of their job. We can't quite separate lifetime traumatic events from job-related traumatic events in terms of saying it's because of the clients. No, I think we have to say it in part it's because of the environment in which they work. And what we have to do with that, and it's just so simple and it's not been done a lot of the time, is we have to tell people who are applying to work in this kind of environment that it's a tough situation that you're walking into. And it's not one that is, it's not one for which everyone is equipped to work, either by way of training or just in terms of who we are as people. And if we can help people to accept the fact that it is not necessarily an easy place to work, that in and of itself seems to help people to be able to talk about it on the job, and that in turn reduces some of the traumatic stress. It doesn't make it all go away, but reduces it a little bit. So I don't think we can really blame the clients for the fact that they walk in with problems. We just have to help staff to address what their own reactions to that are going to be. Tracy, I think Eric is supposed to be part of this panel, but I think that he got bumped out of Zoom and can't make it back in. I'm not sure.
I'm here, but I don't think I'm part of the panel.
I'm sorry.
I think the onus is on you.
And on Tracy, I'm going to share it with her and Ashley.
And Ashley, perhaps you could talk about harm reduction services that have been impacted for the incarcerated population and what your experience with COVID has been in that regard.
Sure. Yeah. I guess I'll provide a little context about the correctional center. So we house clients that are remanded into custody awaiting trial, or clients that have been sentenced 2 years less a day. So during this time, we at the St. John Correctional Center were designated the COVID center. So any client who tested positive within the province would be transferred to us for care. So consequently, like our preoccupation, or we were preoccupied with COVID this whole entire time. It was all our resources were reallocated to deal with COVID. This meant like some initiatives like the methadone program and the Suboxone program were put on hold. So we would maintain clients coming in if they were on methadone or Suboxone. We'd maintain them at their dose that they came in with, but we wouldn't be starting clients because we just did not have the resources to deal with COVID, as well as start people on the program because of staffing shortages and the extra policies and procedures we had to follow with public health. So it really limited our ability to start people and really like everything was put on hold. We were really preoccupied with COVID, and we continue to be preoccupied with COVID, unfortunately. And like as far as like the stressful side of it, I'd say we're 2 years into this, and I think the most stressful time was at the beginning of this year. So 2 years into this, and it still remains like very stressful time.
I'm wondering if any of you could speak to any long-term ongoing impacts that COVID is going to present for harm reduction efforts. I know that we witnessed a number of lockdowns in our community and in others, and that had quite a negative impact on outreach efforts, on harm reduction possibilities and programs. And I'm just wondering if I can try to get a sense of any ongoing challenges or any long-term consequences that the pandemic has made for us.
I think one aspect of that is just leading up to COVID, there was a lot of momentum in a lot of areas for harm reduction. I think there was a lot of momentum in trying to improve the hospital's policies around harm reduction and trying to make it a safer and more welcoming and accepting place for people who use drugs. And we had all these great things that we were developing, all these policies that we were putting into place. And I would say that was 2 years ago, and it feels like ever since everything's been on the back burner. I think a lot of things, especially around public health, everything is really on the back burner except for COVID for the time being. And so we've lost a lot of momentum and a lot of programs that I think could have had a lot of benefit for our population. So I suspect that has been quite a significant issue.
And I may add from out here in Alberta that I think in some ways you've been able to maintain your ground better than we have here. And in part it's COVID, but in part it's the political environment. And so we're currently in a political environment that's not particularly inspired by harm reduction and has made efforts to close some of the safe consumption sites. And during COVID, that has been a double whammy because people have fewer resources that they can turn to that they feel that are safe. And even in some of these safe consumption sites, they're now requesting that people provide their healthcare card and identification. We know not everybody wants to do that. I mean, it's really creating a double jeopardy. Even if we decriminalize or try to move away from the criminalization of substance possession, when you're asking people to provide their healthcare information, we all know how badly that goes down. So I would say that it's hard at this point, at least out west, to separate COVID from the UCP. There you go. That's the United Conservative Party in Alberta, which I'm not a particular fan of, as you might gather. So, you know, I don't think we can talk about harm reduction without accepting the fact that there has to be a political will to support these efforts. And without that political will, we're going to be doing a lot of marching in the streets like the suffragettes looking for the vote. I'm sorry, I don't know where that came from, but I think you get the idea.
Important view from Wild Rose Country. Perhaps the local folks from Horizon, can they speak to the lockdowns and the impact that had on harm reduction? And I guess I'm trying to get on what does this mean going forward? What does this if we have to self-isolate again, if we have to get ready for our subsequent waves or more virulent strains of COVID, what does that really mean for harm reduction efforts, and what do we have to do as a community to get ready?
I think one of the biggest challenges during the isolation periods was that I deal with a lot of patients who are in various stages of recovery. And oftentimes during recovery, there's already a very isolating period where you lose your social circle. And that often is a big component of recovery, because if your main social circle is a bunch of people who also use drugs and you're trying to get away from that, you often go through a period where you lose a lot of friends as well. And so a big component of seeing a lot of my patients is actually discussing what are other alternatives, what are options for developing social circles, where can they access just that ability to have that human connection with people again. And when you suddenly go into an isolation and they don't have those options available to them, I saw a lot of isolation in my patients, and it was very challenging for a lot of them. The ones that went into COVID with a good family circle, with a good tight community, they tended to do all right. It was the ones that went in already having issues where they were perhaps losing the social circle that they've had for years. And I mean, oftentimes they get a lot out of those social circles, even if they're not always the most positive influences. And so if you lose those people from your life and then you don't have any alternative options available to you because everything's shut down, it becomes even more isolating. And so I saw some people actually just fully destabilized because they ended up going back to some of the people that they had been with earlier. So I think one thing that's really changed now that things are opening up again is I do often try to have a lot of discussions around what like brainstorming around what resources are available for people to create new social networks, new friends. There's some really great programs throughout St. John, but that those can be precarious due to the isolation that we went through. And so hopefully we'll see that will improve. But again, a lot of the ways that we worked around that are things that require a lot of technology. Right now, this is all technology. This whole Zoom meeting is based on all of us having at least some form of internet access and computers or iPads. And so not a lot of our patients have that. So telling them that they can go to a recovery meeting via Zoom is not very accessible for everybody, unfortunately. And so I think having resources that are not technology driven would be really beneficial. And then also just making sure that there are some things that can remain open, but still keep them at a as clean of environment as possible. I kept my clinic running the entire time of COVID, and I continue to see patients, as many of them as possible, in person. I definitely did some appointments over the phone, but if patients wanted to come in and see me, I never said no. And a component of that was I noticed that a lot of my appointments suddenly became like double in length. And part of that reason was because for a stretch there, I think I was the sole social interaction for some of my patients. And I just had to accept that was going to become a part of my clinic day, was letting it become a bit of social time for the people. And again, in a very clean environment and wiping down all the surfaces in between and wearing our masks. But I think we need to recognize the importance of human interaction in recovery.
Tracy, it's Sarah. Would you even argue that that is actually some of the positive experience that we as clinicians can actually use to sort of combat our own adversity in these situations? Like sometimes it's actually, I don't know, it's almost leveled the playing field because we all felt the adversity of COVID in some degree or another. Is that sometimes sitting down with patients or clients, wherever you are, is sort of, it kind of made your day sometimes. Like it was social for me too.
Yeah, I would definitely agree with that. When I was talking earlier about some of the issues around burnout, I recognized that I was perhaps discussing more the emergency department, because actually there was often times where I was looking forward to the clinic far more than I was any of my shifts in the emerge, mostly because it was a far more pleasant environment.
But you know what? I'm going to challenge you a little bit, Tracy, about the fact that you mentioned burnout, but you also said very interestingly that your staff continued to be engaged and tried to find ways that you could reach out and do some other proactive things. And I would suggest to you that is exactly what I'm talking about. People were stressed out, but they still cared. They still wanted to be there, even though they knew that they were emotionally exhausted sometimes. And that emotional exhaustion can lead to that kind of angry, frustrated, not doing the best that you really want to do for your patients, but it's not because you no longer give a damn. It's I look at people who are burned out as people who no longer give a damn, but that being stressed out comes from a slightly different place, because it's hard to care and then to at the same time know you're not doing your best because you're so strung out. That's in some ways a much tougher place to be.
Yes. And I'll let you respond, Tracy, but I just wanted to say, and are there lessons learned from that about how to mobilize as a group, how to innovate, how to do business differently? What have we learned from all of this that actually kind of means that we are taking things as a different approach and a different angle, whether that be our own self-care, whether that be how we deliver care? I'd love to think about some of the aspirational things that we think moving forward now that we can leverage.
Really important comment. I think one of the things that we need to remember is that trauma-informed care is not just about recognizing that our clients may have trauma. It's about recognizing that we are all have experiences with trauma and we can all be impacted. that the extent to which our lives are controlled by other people creates usually a negative pushback reaction in most of us. It's no surprising that we're seeing a great deal more civil protests and civil disobedience. I think it's angry people frustrated without a place to vent and deal with that. So recognizing that that this is part of an inherent response, and it may be trauma-induced response, I think it's important. Sometimes if you recognize and can give voice to something, it helps to reduce the burden of it. Doesn't make it all go away. We still need to do the self-care and a lot of other things, but at least we take the elephant out of the room and give it a name and say, okay, we're all subject to this, and we've all been impacted by it in a way that we have not seen in the history of mankind, because this has been universal in a way that we cannot see the universality. And, you know, I think when we're talking about clients, they may have less time, opportunity to really do that kind of reflection, and they need that kind of reflection as well. Anyway, going off, somebody else jump in. Sarah, did you want to add some stuff to that?
Oh, I want to leave space for Ashley and Tracy for sure. So I'll let them respond, and then I'll open my mouth later if I can't help myself.
So I was just going to say, I think there's been, definitely the trauma has been contributing, the interactions, but I think I've also created a lot of good connections with patients around this time period as well. And so there has been just the ability to have longer conversations, the ability to interact. I think there's been a lot of benefit. One thing that actually interesting, I was saying I try to keep the clinic available for patients to come in to see me, but at the same time, New Brunswick is a very rural province. And so one of the biggest barriers that I would often have with patients prior to COVID was getting them to actually come to clinic on a regular basis. And if you try to follow some of the guidelines, there's a certain amount of overseeing that you need to be able to do in order to prescribe safely. And I think a lot of the rules around that have changed a lot during COVID, which has actually opened it up and made it much more available to people throughout the province. I have a lot of patients who live down in Charlotte County, which for Jeanette, if you don't know, that's about an hour away. And for people who obviously can't afford gas in these time periods, that's a very long hour. But then suddenly to be able to have these virtual clinic meetings with them instead of constantly making them come down to see me on a somewhat regular basis, I think it actually has been it's made the clinic more accessible to people as well. So I think there have been some benefits in some of the changes that have occurred due to COVID, and I'm hoping that that does continue.
Well, that's helpful. It's nice to know that there are some parts of this experience that might be of some kind of benefit. I'm just wondering if some of the PTSD or vicarious trauma or burnout that we've talked about, in your opinions, how long lasting is that likely to be? And what can we do to remedy that or to address those consequences that have flowed that we're worried about now? Does anybody have any comment or thought on that? How long lasting it may be, or what the remedy would be for some of that?
Are you asking for our crystal ball, Randy?
Of course, gaze into it, Jeanette. What do you see?
Oh, you know, I mean, I think that one of the responses that I can see happening now is as the angst about pervasive COVID has gone down, as we're loosening up, people are feeling a little less being controlled. And I think that reduces the stressful response as well, because part of the stress is out of being involved in a situation where I have no control, I can't fight the enemy, and staying put is about the only thing I can do, which are really, you know, classic stress responses. So what I'm thinking of is part of what we're all dealing with, whether it's our clients or ourselves is what I call a pervasive COVID-related traumatic response. And that as the worry over COVID recedes, it may always be there to a lower level, but we'll be able to cope with it better. And we will at least know that there are some things we can do to help ourselves and help others. That will be good. And I think that the other thing that comes out of that will be also an appreciation of the things we've learned during COVID that are helpful, that we can use going forward, and the things that we've learned that are not helpful. So one of the things that's not helpful is too much Zoom time, because while Zoom is important and it's really helpful, and I agree with Tracy that especially in rural, for people who live in rural areas, that being able to connect over Zoom is better than not connecting at all. And yet we know that in-person connection is also important. So being able to differentially know how much we can do online and how much we need to do in person, so that we have a balance of the two. And I think that that will be helpful too. We'll get a more of a sense back of having control of our lives. And I think that part of the response that we've had is we haven't had the control that we need and we want, that keeps us healthy. So I think that the response will go down. And I think we will come out at a different place. But but exactly how we will all configure that within society is still a work in progress.
Thank you. And do the other two want to take a stab at looking in the future?
I think Ashley, you're about to say something?
Oh, no, you go ahead.
No, okay. I was going to say, it's the whole crystal ball thing is very challenging. I suspect the people that are involved in harm reduction are in it because we love it, because we love the patient population. And I don't think the reason why we're in it is partially because of, you like to believe everything's altruistic, that you like to believe that there's altruistic components to things. But I think there is a component of you're in it because it makes you feel good. It makes you feel like you're helping somebody. And I guess in one aspect, that hasn't actually changed with COVID. And in fact, it's almost been the opposite. I find the differences that we've made in people's lives are even bigger now. And so because of that, I feel like the issues around burnout and vicarious trauma, I agree with Jeanette to come to a big component that actually I feel it less in the harm reduction side of things than I do in the direct, like the standard healthcare side of things. And I believe part of that's just because of the patient population and dealing, and so although there is a component of that, I think people who are involved in harm reduction are still going to be here. I think we're still going to be doing the work that we do. And so I don't think we're going to see it as much on our side as we will in other aspects of healthcare.
Thank you. And actually, there was a question that actually has come in for you. Are there any plans to reintroduce Suboxone in the corrections at this time that you're aware of?
Yeah, I think we're still struggling with, like everywhere else, shortages, staffing shortages, but there are plans to start with a methadone nurse. So hopefully that'll come into play here sometime in the immediate future. Again, I think we have 2 vacant staffing spots right now. So once those are filled, we'll be in a better position to reinitiate that program.
Thank you. And we've run out of questions in the chat, and I know it's hard to put people on the spot at a time like this for something like harm reduction and COVID. Last chance to panelists. Any final comments before we sort of wrap up and head to the next section on this?
I just want to say one final thing, and that is we've been talking a lot about the direct service providers and about the clients. We also in the study that we just completed, we also interviewed 42 managers and supervisors in shelter programs. And just to relate it to the COVID situation, one of the things that they pointed out was while there were many challenges in terms of restrictions of services and inability to provide the harm reduction services that clients needed, et cetera, they also saw it as an opportunity to implement new programs and policies that had been perhaps sitting on the back burner or talked about but never enacted, an opportunity to appreciate more the importance of the work that staff was doing. And so the message that I would like to leave everyone with is that COVID, as awful as it has been for most of us, has created some new opportunities, and we are seeing that that there is some value in what we've had to do to reconfigure ourselves to move forward. So it hasn't all been negative.
Thank you, Jeanette. Ashley or Tracy, any final comments?
Tracy, you must admit that we learned that they can create a clinical order set in 48 hours, and before COVID, it took 2 years.
That is true. There is an efficiency to some of the realizing that you don't need to have an in-person meeting for everything. So.
Mm-hmm.
Well, great.
Okay.
Oh, sorry. Did I interrupt? No, I guess that's it. I want to thank the panelists very much for trying to guide us in this conversation about COVID and harm reduction and what it means going forward and really what it's done to us as we've tried to cope with this. We have a couple of pieces left on our program today, both very important for us. We've always had Kim Wilbur talk to us and offer a memorial to those that have been lost over the last year. And if Kim is available now, I would turn the floor over to her. After once again, thanking very much our panelists and wishing them well and thanking them for the participation today.
On behalf of the Harm Reduction Symposium Organizing Committee, I would like us to take a moment to remember our colleagues who are no longer with us. Judith Meinert. Judith was a driving force in the founding and growth of Avenue B Harm Reduction, formerly AIDS St. John. She brought an energy, insight, color, determination to the organization in meeting the needs of clients. She was empathetic to their dilemma and worked passionately to ensure each person was treated with dignity and respect. Many would say she was a kindness specialist. Judith saw the value in everyone she met. She played many roles at Avenue B over the past 30 years. She was executive director, a member of the board of directors, fundraiser, educator, and volunteer extraordinaire. She was loved by all for her passion and endless commitment. She was particularly a favorite with clients for her colorful outfits, her caring presence in their lives. Judith will be missed tremendously by her friends at Everywhere and especially at Avenue B. Our colleague James Foley. Boston Jim was born on October the 13th, 1967, and passed away on September 6, 2021. Jim was a very familiar face at Avenue B for many years, always wanting to lend a hand, thankful for all the help and support he received. He took part in the Avenue B project for peers in 2014 and completed the Peer Helper Handbook. He then was one of the Peer Health Navigators, another project that started in 2018. He was thrilled to be out on the street, helping and supporting in any way he could. He was so proud to be a part of the project and be involved with the production of the Avenue B video. Boston Jim was a joy to have around. He was there for people whether he knew them or not. And he was the kind of guy that you would instantly like and left an everlasting impression on all who knew him. Let us now quietly reflect and remember our friends, family members, and those people who are so important to us. Karen, Melissa, Sherry, Reed, Patrick, Alana, Matthew, Tyrell, Brandon, Carl, Brevin, Tracy, Michael, Tyler, Cody, Mary, Francis, Robert, Neil, Colin, David, Georgia, Nadine, JP, Jeff, Tanya, Randy, Douglas, Marshall, Joseph, Brian, Daryl, Troy, Jeannie, Maddie, Sassoon, Daniel, Wayne, Jessica, Pat, Jesse, Andrea, Henry, Van Long, Phil, Skylar, Courtney, Chris, Dustin, John, Rafi, Lyle, Van, Randy, Edward, Travis, John, Jesse, Dex, Katie, Riley, Verna, Seamus, Alfred, Colin, Brennan, Jason, Tiffany, Stephen, Terry, Melissa, Courtney, Sean, James, Jack, Quinn, Shelley, Brian, Lisa, Cash, Donnie, Red, Samantha, Larry, Kelsey, Cash, Dan, Travis, Lindsay, Brian, Nat, Quinn, Jeff, Danny, Jay, Donnie, Troy, James, Jesse, Michael, Bruce, Rusty, Charlie, David, Matthew, Tegan, and Michaela, and all those who lost their lives through prohibition, criminalization, and homelessness. It is time for a safer future. Thank you.
Thank you very much, Kim. That's always a very moving way to spend a few moments at these annual harm reduction symposiums. To wrap up now, I'm going to call upon Julie Dingwell, who we have met earlier today, and those of us in St. John will tune in to CBC Radio and listen to again tomorrow morning for some closing remarks. I would just like to take this opportunity to thank very much the panelists, the participants, and you for joining us today. Thanks very much. Julie, over to you for final thoughts.
Well, I'm not going to keep anybody too long. I just have to applaud all these people that stayed right through to the end. So again, I'm going to finish off. I'm always just broken after I hear that list of names. It's like when I started today, I told you I couldn't even remember all of the people that have passed since I began here. So I'm going to just ask you to show a little bit of kindness, go out there and be kind to people. The year before last, I told you about somebody that actually bought somebody a car. That was somebody that bought a young mother single mother a car. So, and then last year I said, you know, pay somebody's rent. So this year I know times are hard and times are hard for everybody, but we can still be kind. And, you know, if you can give somebody a $10 Tim's card, that makes somebody's day. Maybe buy somebody a grocery order, depending on what you can do to be kind for somebody else. And just remember, we're all in this together, and it really does, it takes a country. So thank you everybody for coming, and we'll see you next year.